please be aware that this meeting is being recorded. So we want to make sure that everyone is aware of that from the outset. And then finally, please be aware that we have our Vivax Hub. It's a website that we use that hosts many of the resources that PAVE has produced with the work that we're producing across the world. And it should be a resource to you both for this meeting and following the meeting. And so with that, I'll quickly go over our meeting agenda. Please be aware that the objective of what we're trying to accomplish today is to make sure that we have a space to do a deep dive into many of the implementation efforts that our work has been focused on over the course of the last year here in Latin America. We're hoping that this space can be a platform to exchange lessons learned from the field, as well as to discuss policy perspectives and operational challenges. Given that, what we'll just to quickly walk through the agenda, what we have planned is our opening session right now, which will continue for another 20 minutes. That will be followed by a session that's focused, will be a deep dive into the pilot implementation efforts that we have been conducting with many of the partners who are here on this call, from whom you will hear directly, including Colombia, Guatemala, Honduras, and Panama, where they've been really leading the charge in Central America and part of South America to introduce G6PD testing as part of their, within their national malaria programs. Followed by a short break, we'll do a deep dive into the experience in Brazil, where we will hear from our partners about the experience of not just the implications and learnings from the trust study, which concluded last year, but the operational aspects and learnings from that experience, and then moving forward toward the introduction of new tools for radical cure into Brazil's single united health system. And that will be followed by a 10-minute, 15-minute Q&A session. The next session will be focused on how we're planning on reaching special populations. And so that will do a deep dive into specific and unique populations across the border area in Colombia and Panama, as well as outreach to the Yanomami population in Brazil, and addressing the pediatric challenges around malaria transmission in Peru. And then we'll finally close by hearing some words from a regional perspective from PAHO, the Pan American Health Organization, as well as some closing remarks from our leadership and donors who support our work. And so with that, I'm happy to kick off our this opening session. I will share my screen and invite Elodie, who will also accompany me in sharing a quick overview of PAVE and the work that we've been doing to set the tone for today's meeting. So with this, everyone's sharing. Can I get a quick confirmation that my screen's sharing correctly?
Yep.
Thank you, Elodie. So thank you again. And just to give a quick overview about PAVE and the work that we've been working alongside with many of you on in the region. We're really focusing, well, PAVE is a consortium of different organizations and partners, including research institutions, national malaria programs, regional technical partners, private sector actors, et cetera, who are coming together under the leadership of both MMV and PATH to explore how new tools can further accelerate the pathway toward malaria elimination, specifically on Vivax, here, not just here in Latin America, but also around the globe. And so our focus has been producing locally generated evidence, understanding the gaps and barriers for the introduction of new tools, specifically a G6PD quantitative test that's able to be used at points of care, as well as new formulations of not just Permaquin, specifically a pediatric formulation that's in development, but also tefenoquine, which is a single dose radical cure solution for folks with malaria Vivax infection. And of course, because many of the countries that make up Latin America have a long history of using a 7-day to 14-day Permaquin, what we're hopeful is that the introduction of tefenoquine with G6PD testing can be a very powerful complement to the radical cure solutions that exist on the table today to fortify elimination efforts by way of increasing adherence to radical cure treatments and consequently reducing frequency and instances of relapse. And again, we're doing that by supporting the local generation of evidence, understanding countries, understanding the gaps and challenges to the introduction of these new tools and the development of new treatment solutions. We're also, beyond some of those initial points, also working to help understand, once we have an understanding of the body of evidence that exists around these tools, trying to help national malaria programs with policy change questions and understanding the process for updating national treatment guidelines, supporting them in procurement and access to these new tools, and the rollout and introduction of them across their national territories. PAVE has been active across 15 countries around the globe, and I will hand that over to Elodie to talk about that in greater detail.
Yeah, thank you so much, Jamil. So as you can see on this map, actually, PAVE has really a global reach from Meso and Latin America to the Horn of Africa and to the Asia-Pacific region. And our work has really covered market landscaping and supporting national program in the creation of strategies for optimizing Vivax radical cure, and then preparing for the launch of new radical cure tools, which has included operational research and feasibility studies, as Jamil just mentioned, and as well supporting market entry and in a few countries scaling up access to new tools. And if we go to the next slide, you will see that this one outlines in a bit more detail some of the area of work that we have been focusing on. And we have really supported the development of 14 country landscapes and held 7 readiness workshops to support national program in developing their national strategy. And really important to notice that there are 7 feasibility studies, either recently completed or ongoing or about to start. And you will hear a bit more about all of those in a minute in a different session that will come up soon. And these also, of course, include the landmark trust study in Brazil, where more than 6,000 patients were enrolled across Manaus and Porto Velho. And we heard, very exciting to let you know that we heard last week actually that the Lancet Global Health has just accepted the publication for trust. So this is really very exciting, and we very much look forward to disseminating the results to everyone. And you will have also the pleasure in hearing from Delio Pereira, the co-PI of the trust study, as well as from Marcelo Brito, the trust study coordinator, later today on that experience. And then there are also pilot implementation of G6PD testing that have been done, that PAVE has supported throughout Latin America. And again, you will hear more about those experiences in Colombia, Guatemala, Honduras, and Panama in our next session. Then finally, it is super exciting really to see that we are now in a market entry and scale-up phase for several countries, and with really very exciting progress in Peru and Brazil for this specific region. And over to you, Jamil. Thank you.
Thank you, Elodie, for that very helpful overview. And just to round this out, specifically over the course of the last couple of years, PAVE's work began back in 2018 with initial support from the Bill and Melinda Gates Foundation. And since then, despite the challenges that we've seen along the way, including the very difficult challenges of trying to move forward with the acceleration and implementation of this project, despite the COVID pandemic, COVID-19 pandemic, we've been able over the course of the last 2 years see a lot of acceleration in the work that we've been conducting across the region. And so this is just an overall highlight of the work that's been taking place over the course of 2002 and 2022 and 2023. And you'll hear much of this in greater detail from the leaders in the research institutions that we've been collaborating with and from the national malaria programs who have been on the ground implementing this work directly. That includes not just the trust and feasibility study that we've been seeing that has concluded in Brazil that Elodie was just speaking about, but also the health economic studies and other inputs that were necessary for then formed the dossier that was presented in Brazil and led to Brazil's recent decision to introduce G6PD testing of radical cure into the national health program, which will be taking place, which we'll hear more about later today. The creation of a pilot educational program out of Brazil to really understand and have a platform for training on G6PD testing and the subsequent pilot implementation that's taking place there now, the host of pilot implementation programs for G6PD testing across Central America. And then finally, the feasibility study that's currently underway and supported by UNITAID in Peru, and that we're expecting to have results, interim results for in 2024. All of this has been a very exciting work that has been supported because of that initial catalytic support from the Bill and Melinda Gates Foundation. And it's really unlocked the possibility for not just seeing this work taking place, but also what we're expecting to see over the course of the next several years with the continued rollout of radical cure tools in Brazil, the anticipated procurement of G6PD tests with the support of Global Fund in Honduras, among other catalytic effects that we're seeing from these initial investments. And so given that, with the continued support of UNITAID that has also supported this PAVE work alongside the Bill and Melinda Gates Foundation, we're looking forward over the course of the coming years to not just to continue providing technical support to partners in the region in around these questions of radical cure and the continued introduction of these tools into health systems, making accessible the full range of training and educational materials that have been developed over the course of these pilot implementations, feasibility studies for the last 2 years for partners that are interested in continuing to expand out these tools into their health systems. We will continue our regional meetings both in 2024 and 2025, much like the one that you're participating in today. We're excited to increase access to pediatric formulations of radical cure, of which tafenoquine is currently in the process of being registered in several countries here in Latin America, and has recently been approved in Brazil for its the health registry by Anvisa. As I've already mentioned, the continued rollout and subsequent dissemination of results from Peru's feasibility study that's being supported by UNITAID, and finally continuing to facilitate these spaces for exchange between partners in the region that are committed to understanding and accelerating the introduction of these radical cure tools. And so with that, that's our conclusion for an introduction to our to PAVE. And with that, I want to offer I would like to invite some of our partners online to offer some additional words of welcome to close out this initial session. With that, I will hand the floor over to Angelica Espinosa Barbosa Miranda of the Ministry of Health in Brazil, who serves as the Deputy Secretary of Health and Environment Surveillance within Brazil's Ministry of Health. Just wanting to check, so we're handing the word over to Angelica. I'm not sure if you're online. If not, in the meanwhile, we'll hand the word over to Eric Ricardo Peña, who's serving as the Vice Minister of Public Health here in Peru.
Sí, buenos días con todos.
Hello, good morning.
Muchas gracias
Thank you very much for the invitation.
por la invitación. Efectivamente,
Thank you,
para el
Jamil.
Ministerio de Salud
And yes, for
es
the Health Ministry,
importantísimo
it is
estar
of
en este
prime
evento,
importance to participate
toda vez
in
de que
this
constituye una
meeting,
oportunidad para
in this
nuestro
regional
país de
PAVE
avanzar
meeting,
con
since it's an
el
opportunity to
propósito
make
de
progress
eliminar la malaria
to
en nuestro
eliminate
país.
malaria in our country.
Efectivamente, nosotros
And
estamos
yes,
muy
in fact,
interesados en
we're
avanzar
really
con la
interested
implementación
in making
de la
progress with
eliminación a
the
través de estas
implementation
nuevas
of elimination
tecnologías
through
como la
these new technologies,
tefenoquina
and too,
y la
as it is the case
implementación,
with
obviamente,
tefenoquine
el
and the quick
dosaje de
implementation
G6PD
of
previamente para garantizar la implementación adecuada de
G6PD
esta
testing for
intervención,
the implementation of
además
this
de avanzar
intervention,
con
apart
otras nuevas
from
tecnologías
making
que nos
progress
permitan
with
reducir
all
al
the
máximo
technologies that can really
este problema
reduce
sanitario, problema de salud
this
pública, que si bien
public
está
health
focalizado
problem,
en la
which
selva de
of
nuestro
course
país, en la
it is
región
located in
específicamente
the
de
jungle
Loreto,
at the Loreto
independientemente de
area
esto,
in our
para
country.
nosotros es
Regardless
sumamente
of this
importante
location, it is a
también
top priority in
reducir
our
el riesgo
ministry to
de
reduce the
propagación
risk
en algunas regiones que ya
of
vienen presentando algunos casos
contamination
del
in other
problema de
regions that are
malaria.
currently having
Nuevamente, nuestro
an
compromiso
increase in
del señor
malaria
ministro de Salud,
patients.
del Estado
Our
peruano,
Ministry of
para
Health
continuar en el
in Peru
escalamiento de estas iniciativas,
confirms
de
the ministry's
incorporar la
participation to
evidencia
incorporate
científica generada
scientific
precisamente
evidence generated
en estos
in
trabajos
these
desarrollados a través de la
meetings and
cooperación de estas
papers
instituciones
developed
supranacionales,
in the
que nos van a
transnational
permitir
institution cooperation that
precisamente
are the input we
implementar
need
intervenciones
for the
informadas en
quick
evidencia y que
implementation of
definitivamente van a
evidence-based initiatives
convertirse
that will,
en
of course,
las
become the
estrategias o las
standard
herramientas
and the
a
strategies
través de
and
las cuales
tools that we
alcancemos el
need
objetivo final, que es
to fulfill the
la
final
eliminación de la malaria en nuestro país.
which is to eliminate malaria in our country.
Muchas gracias.
Thank you very much for having me here.
And with that, we'll conclude our opening session for this meeting. So thank you again for all of you for your time and for your participation over the next few hours. You've heard enough out of me, and I'm happy to hand the microphone over to Juliet Mina of the Clinton Health Access Initiative, who will introduce and facilitate this next session. Thank you all. Over.
Thank you, Jamil. Thank you, everyone, for joining us to this session. This session has the idea to give a high-level overview of about the implementation of pilot GCPD testing in Latin America. We are continuing with the presentation from Colombia, Panama, Guatemala, and Honduras. The idea is the people working in the Ministry of Health with this pilot give some updates about the implementation in each country. At the end of this session, we are doing a interview session. It's not like open a question session, but the partners will answer some question about the implementation process. With that, I will start with the Dr. Lina Zuluaga from Colombia. She is the professor of the National School of Public Health in the University of Antioquia, and he is a associate research in the university. Please, Dr. Lina, you can share your screen.
Gracias, Juliet. Thank you, Juliet. Can I share my screen, please? Thank you. You can share it yourself, Lina. Sí. Well, Hello, good morning, and thank you very much for the invitation to participate at the PAVE Regional Meeting 2023. It's an honor to talk about progress made in the implementation of the pilot implementation testing of G6PD in Colombia and Antioquia. So I will share with you the design of the pilot implementation of G6PD testing, lessons learned, and progress. Well, the purpose of this implementation pilot testing was to assess technical capabilities and compliance of the recommendations of the use of testing and guidelines to implement this treatment with public health professionals and try to identify barriers identified by public health professionals and patients during the implementation of this pilot implementation of G6PD testing. We started to carry out this pilot in Quibdó in 5 points of care, which is one of the most affected cities in the area. In Quibdó, in Chocó department, 1 point of care was in the urban center, and we also established 2 locations of the pilot in the rural areas, totaling 5 pilots. Well, the design of the pilot testing was divided in 5 stages. First, training of healthcare professionals in a workshop for the implementation in the 5 locations, assessing cognitive and procedure capabilities after training personnel, socializing education material, and we handed over testing recommendations. Week number 2, well, healthcare professionals had the opportunity to try to check the tests and quality control compliance, going over the content of education material with remote supervision. And in the 3rd stage, weeks 3 to 9, underway right now, we are testing patients that are infected by Vivax or mixed malaria above 18 years of age with primaquine 8 weeks. For patients with deficient enzyme activity with phone follow-up to see if there are any hemolysis signs and remote supervision of healthcare professionals. Follow-up visits include recommendations, identification of barriers, and an interview to see if there are any problems in the implementation and validation of education material for healthcare professionals and patients. And well, we also will perform in the future a closing visit with the recommendations that will be sent to the health ministry in Colombia. Well, we have tested 56 Vivax or mixed malaria patients in different points of service, as you can see here, in the different points of care, and look at the figures on screen. In all the cases, we have appropriately implemented 8-week treatment for deficient enzyme individuals. And we also provided technical support in the first 2 weeks of the private testing and communication with healthcare professionals. For the moment, which are the lessons learned? Well, the methodology designed in the education program for the training of these healthcare professionals is appropriate. All of the participants had percentages of approval that were above 80% in success rates. And we consider that the previous week before the implementation of the pilot was very useful. There was a low technical support demand in the 2 critical weeks. And the different questions had to do with inclusion criteria, follow-up questions, and very specific treatment issues and technical issues related to G6PD testing. Well, there were some issues with the control mode and the analyzer, considering that they had to change the control levels and the report of enzyme activity when the enzyme is below 7 grams per deciliters. We had very satisfactory compliance levels, and we thought that there was a positive feedback in the follow-up of recommendations on the use of the tests. Healthcare professionals understand and are able to transmit key information of the importance of G6PD testing that was included in the education program. So this is the reason why there is high levels of acceptance by patients, but we also need time to help our users understand why we need G6PD testing and malaria treatment. We believe that the education material posters are very positive, even though we need to change the format of some education items. Medical personnel has no relevant information on testing. Those technicians that provide the testing believe that they need more time to focus on other pieces of information that have to do with the informed consent procedures and telephone follow-up. The time allocated to give patients key information and procedure is 5 minutes. And healthcare professionals believe that, yes, the test is very easy to take. There is no perception on any type of overwork, but this is maybe related to the fact that the selected points of care are the ones that we saw before. Thank you very much for your attention. Thank you, Dr. Zulaga, for your presentation. Now we will give the floor to Guatemala with Dr. Jose Miguel Echeverria, National Malaria Laboratory Network from the Ministry of Health in Guatemala. Dr. Echeverria, thank you very much for being with us today to talk about the situation in Guatemala.
Gracias, muy buenos días.
Thank you. Yes, thank you. Good morning. Can you hear me? Yes, we can, doctor. Hello, good morning. Thank you for having me. Can you see my shared screen? Yes.
El PAI y de PAVE está puesta a punto y implementación inicial de la prueba que se PAVE a nivel de campo, y es una experiencia que ha sido muy enriquecedora. Teníamos ya varios años de estar considerando.
Well, let me share with you the information on the pilot implementation of G6PD testing in Guatemala. I am Dr. Jose Miguel Echeverria Barillas from the National Malaria Laboratory Network from the Ministry of Health in Guatemala.
Anecdóticamente, algunos casos donde se pasó. ¿Sí?
Doctor, creo que estamos teniendo algún problema de audio que impide que le podamos escuchar bien. No sé
Dr. Echeverria, I'm sorry, but we can't understand what you're saying.
Está interfiriendo
Permítame un
con...
momento,
I mean, there is an issue here with the audio.
Buenas, no sé si me escuchan mejor ahora.
Mucho mejor, doctor. Muchas gracias.
Sí, es el audífono a veces no funciona bien. Muy bien, entonces resumiendo, les comentaba que ha sido una
Well, I
experiencia.
will start again. So our experience with the pilot implementation of G6PD testing in Guatemala has been very interesting. For many years now, we were really wanting to deal with this issue with malaria patients, and we had some cases in which we had the suspicion of G6PD deficiency in some patients, but due to the difficulty in remote areas to really perform these testing, this was really a barrier that was very hard to overcome and try to identify these cases. So what we did was really use this pilot in a fantastic experience in the remote areas in our country. This is a community-based program based in these locations where we work with local communities so that we can eliminate malaria in these remote villages and communities. I think we have an issue with Dr. Echeverria's connection.
Pero que a la vez el diseño del estudio, pues escogimos, ¿me escucha? Perdón.
Ahora sí, doctor, otra vez.
Yes, we can hear you now. I think that there is a problem with my computer. I will shut my video screen. Well, the design of the pilot took place in 2 locations in the country. First is Quintla, that for many years was the state
Más malaria precisamente el que ocupa
with more malaria patients in the country, with more than 1,000 cases. So we established 5 points of care in Escuintla and in Alta Verapaz since August to November 2023. So it's currently underway. So we identified key locations to identify positive cases in this short period with demographic differences, because the Alta Verapaz region is a Kipchi ethnical group of the indigenous peoples, Kipchis. And in the south, in Escuintla, we have mixed populations. So we expected some differences due to the demographic mix of the location. In August, we trained healthcare professionals, which was essential for the success of our pilot. We realized technicians needed practical training to understand information and be able to implement the pilot. Training was the most important component for the success of our pilot.
En la aplicación de la prueba, y eso determinará la calidad de los resultados. Realizamos 2 talleres con
We organized 2 workshops with a lot of participation, much more than expected, to train them in the use of tests. We wanted them to have all the information needed for testing our patients. We performed 139 tests. 133 were performed in the Alta Verapaz location, and in La Gomera, we performed 6 tests. In Teleman, we gave 133 tests, and no G6PD deficiency patients were identified in Teleman.
Se pierde la voz, ¿eh?
El desarrollo del estudio. Perdón, es la señal acá.
I'm sorry, my internet connection is really bad. I will repeat what I have just said. We had 2 G6PD deficiency patients in La Gomera, Escuintla. So these are total figures. That is 139 patients screened, 2 positive tests. So which are the main lessons learned? Well, first of all, trained technicians is a determinant factor for reliable results. In the beginning, we had a lot of reading issues, mainly due to the fact that there was no good technique in place for testing, because technicians were not present during training sessions, or because the first tests were badly used, because the technicians didn't have the information. But of course, our personnel was really happy to have this test, the quantitative test, because they realized that this would translate in appropriate treatment for malaria patients that would suffer no additional harm if they started using this testing. So they really went out to communities looking for possible patients, and our technicians and healthcare professionals were really committed to follow up, especially for cases in which deficiency in enzyme activity was confirmed. So our technicians and healthcare professionals were really involved and felt empowered by the possibility of providing testing. And of course, as a consequence of the success of this pilot, and considering the safe administration of treatment with comprehensive malaria treatment, including the assessment of hemoglobin levels, and of course, this G6PD testing, we could really know if there were any cases of anemia, and if this was the case, we would refer our patients and provide comprehensive support to our community members. So it was really a very good experience we had in my country. It is really rewarding and interesting in this first implementation, and we believe that it is really very feasible to implement this nationwide in coming years, so that we can really provide Vivax malaria patients the best treatment available. And I apologize for my internet issues. I am really at a hotel room using the best internet connection available. And I don't know if there are comments or questions. I'm available. Thank you, Dr. Echeverria. We will have a Q&A session later. And if there are any questions for you, we will let you know, Dr. Echeverria. And now we will give the floor to Dr. Lorenzo Pavon from the Health Surveillance Unit at the Ministry of Health from Honduras, from the National Malaria Laboratory. Thank you very much for your participation. You can start, Dr. Pavon. Hello. Dr. Mina, good morning. I take this opportunity to share with you the results of the pilot implementation of G6PD testing in Honduras, currently underway in La Mosquitia region. La Mosquitia region I think there is a connectivity issue. I think we have an issue here, doctor. I don't know if you can hear us. I think I'm back. What I was saying is that we're currently implementing the pilot implementation of G6PD testing in Honduras. And we are implementing this in La Mosquita in the jungle. And for this purpose, we've been working with the Health Surveillance Unit personnel from the Ministry of Health, with Dr. Francisco Medina, and with our partner institutions. So Dr. Leslie Chaver will make the presentation. Thank you, Dr. It's Pravon. Dr. Leslie Chaver, you have the floor. Can you hear me?
Buenos días. Buenos días. La escuchamos, doctora. Doctora, si está hablando, no la estamos escuchando.
Doctor, we can't hear you.
Hola, la escuchamos, doctora.
Sí, es que veo que está con pantalla ya, entonces voy a presentar la presentación. El doctor Lorenzo la comenzó a compartir.
Doctor Lorenzo, ¿podría dejar de compartir pantalla para que la doctora Leslie pueda presentar, pueda compartir su pantalla?
Please, Dr. Pavon, could you stop sharing your screen? Now you can share your screen, Dr. Leslie.
Okay, ya la estamos viendo.
There you go. We can see your shared screen, Dr. Chaver.
No me permite, pero
Mm.
vaya dándole continuidad. Doctor Lorenzo.
Sí, diga.
Ya pasó la siguiente diapositiva, doctora.
Es un placer para mí presentarles estos datos recopilando que se desarrolló en la región.
It is a pleasure for me to present the results of the pilot testing that was implemented in Lempira. We can't really hear you, doctor.
La estamos escuchando entrecortado. ¿Podría tal vez apagar el video para ver si...
Maybe if you turn off your video, we will have better connection.
We can also present the slides for you if it's better. Podemos compartir la pantalla para ver si su conexión mejora.
Sí, por favor.
Sí.
Entonces, voy a detener el video.
I will stop my video, and maybe if you share my screen, it'll be better.
Sí, está mejor.
Better now. Okay, so the inclusion criteria for points of care that we're participating in the pilot, that is the pilot design, case concentration in Gracias a Dios area, operational and logistics capacity in points of care, local epidemiology, and monitoring feasibility in the 4 pilot testing initiatives in 4 points of care: DAPAT, Tailibila, Ibans, and the Porto Limpida Hospital. These points of care had a case projection of Vivax cases in blue. This was the forecast of cases to estimate expected cases in the area. And in light blue, the second bar shows the number of expected cases in each point of care. The third bar shows the number of real cases identified in each point of care. So you can see that we had less cases in some points of care than expected. As you can see in the other chart, test approval testing varies according to personnel profile. That is to say, those that took training sessions and participated in the project, if they were microbiologists, physicians, nurses, technicians, had higher approval rates. So we see that some participants rated the results as less satisfactory because we have to remember that we have indigenous peoples in our country, in Honduras, that speak another language. They speak a different language. So this group of indigenous peoples couldn't fully understand what was going on. They had no access to explanations that were carried out in Spanish. Nevertheless, as a lesson learned, microbiologists, highly qualified professionals, had an excellent performance. Well, which were the challenges we encountered and progress made? Well, the implementation of this pilot demanded great experience of professionals involved. And this gave us the possibility to scale up the initiative to other key locations to guarantee radical cure of Vivax malaria patients in the region. The test was really easy to use. Nevertheless, we should train some technical aspects considering the profile of the user. And I go back to the issue of the profile of the user, because if we're talking about illiterate participants, of uneducated participants have a harder time understanding the technical aspects. G6PD deficiency was very complex technically in the past, but with this quantitative testing, we were able to really cover a lot of remote and distant locations. Previous studies show a high G6PD deficiency in the area in Gracias a Dios location. Nevertheless, we have the highest access barriers in this location. It is a real financial challenge to include G6PD diagnosis, but we should include this location to make the radical cure available for everyone. And of course, we have the issue of the language barrier, as I mentioned earlier. Since we have indigenous communities that do not speak Spanish, we need more time to guarantee total understanding of all the participants. And since the quantitative test is not statistically representative, preliminary findings show high deficiency levels. So we need to spread out the implementation of this pilot initiative to guarantee the radical cure of our patients, our Vivax malaria patients. Thank you very much for your attention. Thank you very much for having me. Thank you, Dr. Leslie. And now we give the floor to Dr. Carmen Perez. She is the Vector Control Department Coordinator from the Ministry of Health in Panama. Thank you very much, Dr. Perez, for your participation. Would you like to share the screen, Doctor? Good morning. You can share the screen for me. Thank you. Pilot implementation of G6PD testing in Panama. Thank you very much for the invitation. And on behalf of the Ministry of Health of Panama, we participated in the implementation of the G6PD testing in Panama. Well, what was the goal of our pilot? We wanted to assess the feasibility of using standard G6PD testing for healthcare professionals at the Ministry of Health in Panama and selected communities within endemic malaria areas in our country. Well, the project was implemented in the endemic regions from August to November 2023 in 3 indigenous peoples communities. And who are the target users of our test? Positive malaria cases, with the exception of pregnant women and children below 6 months old. Well, we carried out the pilot in Darien region and Magué region in the cities or communities of Matete, Bajo Chiquito, Santa Catalina, in different point of cares in the 3 selected locations. Well, which is the point of care algorithm? Tests were made for suspect malaria patients. And once we had confirmation of malaria, we would invite the participants to the point of care to take the G6PD test after confirmation of malaria with a positive PDR. So after enzyme activity was established, we started the schedule with primaquine with the administration of 75 milligrams per kilogram, as we can see on screen with the appropriate primaquine schedules. Which are the preliminary results? Well, these are preliminary studies because we haven't validated final results. Well, the number of technical workshop participants, 36 healthcare professionals, medical doctors, laboratory personnel, technicians, nurses, and we had a 92% approval rate. The preliminary results show that testing, according to selection criteria, reached 97%, and the percentage of cases in which the appropriate doses for treatment was 98%. And malaria diagnosed cases in communities in which we perform the G6PD testing, the results are not available yet because we're gathering all the information to reach the final results to upload in the panel. So 76% males, 24% women, and the test was performed by medical professionals and laboratory professionals. So this test was performed by lab personnel and medical doctors due to regulatory restrictions in our country. Which were the challenges we faced? Well, initiatives implemented were the following. In the beginning, we saw that there were some out-of-range results in one of the tests, so we revised the analyzer that was in Bajo Chiquito and Darien communities. One of the challenges that we have in Panama, not only in the interpretation of results and the pilot implementation of testing, but also in the implementation of all strategies, is personnel turnover. In Panama, when we work in remote locations, personnel works 20 days in a row with 10 days off. So this rotation maybe was not positive for the implementation of the program. So each of the locations tried to overcome this situation, trying to train all the technicians and lab operators. Some lab results showed that medical personnel is always checking malaria results. Malaria in Panama is responsibility of the vector unit in the Ministry of Health. But I would say that really healthcare professionals and nurses and lab technicians were really committed to the success of this pilot implementation, and teamwork really helped us overcome all of the problems and barriers in Bajo Chiquito, in Darien, and in Santa Catalina. Which were the lessons learned? Well, in planning, well, community selection was key to identify communities that had the infrastructure to perform the pilot. Because as I said before, some lab tests in Panama must be performed by lab personnel or medical professionals due to the legal framework in our country. So we needed the facilities. So unlike other countries in the region, we need to perform this within the framework of the Ministry of Health. So the training sessions were tailored to the needs for specific training for every type of stakeholder. For instance, for medical doctors, for nurses, and lab technicians with rotation schedules. And what about implementation? Well, field follow-up was essential to implement the pilot and follow-up and supervision for the introduction of new strategies. The lab coordinator was really fantastic in her tasks, and she was responsible for the follow-up and supervision in the implementation of all the strategies. And we also participated in the follow-up and supervision so as to make our pilot successful in Panama. Thank you for your attention. Thank you, Dr. Perez. Thank you very much for all of our speakers from Colombia, Guatemala, Honduras, and Panama sharing your experience in the implementation of the pilot for G6PD testing in these countries. Now, we will have a brief Q&A session with our participants with some questions that we would like to make our panel members so that we can really give the floor to Colombia, Guatemala, Honduras, and Panama 1 or 2 minutes each speaker to answer some questions. I would like to ask our speakers that share their experience. Which was the unforeseen challenge or the main unexpected challenge in the implementation of this pilot in your countries? Unexpected challenges. Dr. Sulaga from Colombia, which was your worst unexpected challenge? Thank you, Juliet. Well, in the beginning, we had a very hard time with the availability of tests. Maybe this delayed the implementation of the pilot, but the technical part, I think that maybe the problem had to do with specific analyzer results when hemoglobin was below 7. We also had patients in which we had malaria complication patients. This is a healthcare center with very complicated malaria patients. So it was difficult to give an answer in this scenario, and healthcare professional questions related to the administration of treatments in deficient patients. But of course, because Colombian guidelines still do not clearly state dosage for these patients. Of course, we had education material for this purpose, but this was the support we needed so that they could really check in the material that we had available, which were the concerns and new guidelines. Another important topic related to this issue has to do with supervision. That is, some issues as far as communication is concerned in rural areas. We believe we have overcome this with appropriate strategies, trying to give an answer to specific concerns raised in remote communities. Technical support was essential during the first 2 weeks, but after this 2 weeks, the learning curve was really great. And we believe that those responsible for testing are now independent. They report results on a weekly basis. Quality controls are in place, and we're doing very good. Thank you. Thank you, Doctor. Dr. Echeverria from Guatemala. Is Dr. Echeverria with us? Maybe we can give the floor to Dr. Chaver from Honduras. Please, you have to unmute yourself, Dr. Chaver. Were there any unexpected challenges? Can you hear me, Juliet? Yes. Thank you. Well, the experience we had in the largest point of care, which was the Puerto Lentira Hospital, well, the experience shared by colleagues and healthcare professionals is that it was really very easy to perform the testing, very easy. And the best thing for everyone was that the results were available in less than 5 minutes. Everything was easy, practical, fast, and the enzyme deficiency was very clearly noted. And a really interesting comment was that the information material supported our professionals during all of the pilot implementation process, because if they forgot a step or a situation, they had written information. So the educational material was user-friendly, easy. So really, this comment, this insight was really positive. Another positive comment was the fact that most patients that arrived at the point of care would arrive during the morning sessions. That is, a lot of time was devoted to paying attention to these patients and giving them timely results. Here in Honduras, results are expected in less than 24 hours, and in Puerto Lentira, thick blood results are also very quick. So this test was fantastic because it is extremely quick. And we can really test our patients and establish whether there is enzyme deficiency or not in 5 minutes. Thank you, Dr. Chaver. Dr. Carmen Perez, would you like to talk about the healthcare professionals' experience? Dr. Leslie made some comments already, but maybe Dr. Perez, would you like to tell us what your experience has been so far as far as challenges and experience other healthcare professionals mentioned? Thank you. One of the main challenges we had in the pilot implementation of G6PD testing, and it is one of the main challenges we have in our country in order to implement the strategy for the elimination of malaria, is that these communities are located in remote and difficult access area. So I believe that this is the case in all the countries in this session. To access remote areas and try to train healthcare professionals is really very hard, because it's very hard to get to these locations, and it is all the more difficult to try to join everyone at one given time in one location. In the case of Panama, training sessions were given for nurses, technicians, and healthcare professionals. And in order to understand these technologies by these educated and trained professionals, this was easy. This was very fast and easy. But this is not the situation in remote and distant areas. I mean, and this is where we have the worst challenges. It is very difficult to get to these locations and train professionals. So in order to really support our personnel, we were present on an ongoing basis, and we were available on location. Thank you, Dr. Perez. And this is a fantastic comment, because it is related to the next question. During the pilot implementation testing, did you need to adjust or change anything? I mean, attention schedule, times available, which were the shortcomings or barriers as far as changes in the pilot? Dr. Lina, well, the adjustment was to include one training week prior to the implementation of the pilot, because when we talk about remote locations, and we need to really train our personnel and make our personnel sure and familiarized with testing before we started the pilot. And with reference to these points of care are diagnosis points of care that work from during the day from 9 to 5. So some patients come to this point of care in rural areas for the diagnosis later at night, maybe. And that's something that we realized, and we would receive patients off hours. And considering the location of analyzers are handled by lab professionals with 24-hour coverage in some distant locations. In other points of care, we work during the day. I would like to make another comment, Juliet. I don't know if this is appropriate, and this is related to what Leslie from Honduras mentioned, that has to do with the differences in the profile of technicians and healthcare professionals. Would this be an appropriate moment to make my comment? Yes, Dr. Lina. Yes, doctor, you can make your comment. Yes, you can. You can make your comment, doctor. Okay, then. So specifically, what I meant is that in our pilot education program, what we did, unlike what we mentioned in Honduras, what we identified was that those that had a technical level or maybe had finished high school, these were voluntaries with microscopy studies, but they don't have a higher level of education. They had the possibility to follow recommendations. They did better than lab professionals. Lab professionals really had a difficult time. And now in the follow-up activities, we found some professionals, maybe due to the trust of the procedure. So we really need to focus on appropriate training procedures, and we need to really focus on technical training. Thank you so much, Dr. Leslie. I don't know if Dr. Echeverria is here. From Guatemala, Dr. Leslie, is there anything that you had to change
se había establecido inicialmente.
Dr. Leslie, there were changes that we had to implement during the pilot. Basically speaking, we tried to really go over the educational material time and again. This was very well accepted by the healthcare professionals. But the number one challenge that we encountered was the language barrier that I mentioned earlier. There is a language barrier because these indigenous communities have their own language, mosquito language. So we had a really hard time to communicate. But of course, some participants were not familiarized with the pieces of equipment or other input, but things were solved. And as I mentioned earlier, you can specifically see that microbiologists had, they really were fantastic. The difficult thing was to train other healthcare professionals that are not microbiologists or lab professionals, especially considering the facilities in these remote locations. We need appropriate professional profile participants in these distant locations that can be trained in these communities. Thank you very much for the question. Well, as far as the implementation, there were no changes. In Panama, there were no last-minute changes. We had to improve everything that had to do team communication. But other than that, there were no last-minute changes to the pilot. Thank you, Doctor. One final question. I know there are many, many questions in the chat. And as I said in the beginning, this was an was an open question panel, but we know that there are so many unanswered questions that we will make all the unanswered questions available to our speakers for later answer. So in order to wrap up our debate, the last question. According to your opinion, can your country or other countries in the region profit from the implementation of G6PD testing? Of course, these pilots were located in very specific areas, but according to the experience of these pilots, do you think that G6PD testing would be positive in your country? Yes, definitely. I can talk on behalf of Colombia, and I would say that the best thing was that we created information material and training tools for those responsible for testing. And this would be our contribution, our education program, and what we have validated in the pilot study that would be available to replicate this across the country. Dr. Leslie? Well, in this specific case, it is really important to train our staff. Installed capacity will stay in the country, and we can replicate these initiatives in other areas other than Gracias a Dios, where these type of initiatives are essential. There is a study in our country that was published in the National Autonomous University by Dr. Fonteco that shows scientifically that there is a 29% prevalence of G6PD deficiency in the indigenous people's mezquita. So it is a fantastic opportunity to be able to really use this input in a positive way. But of course, there is a financial challenge in our country. We know that we need to allocate resources for the implementation of these initiatives. and allocate funds to surveillance in other points of care and locations in our country. So, I mean, the financial challenge that we have in order to overcome our shortcomings and speed up the elimination of Vivax malaria in these remote locations. Thank you. Thank you, Dr. Leslie. Dr. Carmen Perez from Panama. Well, on our side, we're really very happy with what we have accomplished, laying the foundations and establishing the needs of Panama in the face of the prevalence of G6PD deficiency. In Panama, we have only information of screening tests in very few locations. The fact that we have staff, healthcare professionals that are trained to implement this testing is a fantastic step forward. Thank you, Dr. Carmen Perez. Thank you, all participants of this session on the pilot implementation of G6PD testing in 4 Latin American countries. Of course, we have a lot of questions in the chat, but unfortunately, we have time restrictions, but all of the questions will be sent to our participants in order to give them the opportunity to answer these questions. We will take a 10-minute break. Is that so? Can you confirm? Yes. We will take a 10-minute break and we will be back in 10 minutes. Thank you. Okay, then. So, see you in 10 minutes. And we will be right back. Thank you very much for your attention. Stay tuned, and I'll see you in 9 minutes, 42 seconds.
Bueno, muchas gracias. Ahora vamos a
Hello, we will proceed with our next session. My name is Jonathan Novoa. I am the Latin American representative for Medicine for Malaria Venture, MMV, and I will be the chairperson of this meeting. We have a comment here in the chat on the previous session, and the comment is that these are still preliminary results. We will perform a first analysis and we will hold a meeting in December with responsible stakeholders, and we will publish a final report in January. And of course, we will share the report with the rest of the teams. So having said that, we will kick off with our next session called the Brazilian Experience, National Rollout of Tafenoquine and G6PD testing. Our first speaker will be Marcelo Brito. He is a colleague in research studies in the Dr. Hector Vieira Dourado Tropical Medicine Foundation, and he is a member of the Carlos Borgoña Clinical Research Foundation. He will talk about results beyond trust. I guess most of you are familiarized with trust results, beyond trust results that have been published, which is the rollout study. We will talk about the implementation of the study. So Marcelo, you have the floor. Marcelo, let us know if you want to share the screen, if we can help you from here.
Introductions. I share my screen here. Just a minute, please.
Perfecto. La estamos viendo perfectamente, Marcelo.
Thank you, Jonathan. So hello, everyone. First of all, thank you for the invitation to be with you to present some operational points about trust. And so I will present to you some operational aspects of the trust study implementation occurring in Brazil in the last few years. So trust was an implementation survey that takes place in the Brazilian Amazon, more specifically in Manaus and Porto Velho cities in Amazonas and Rondônia states in the north of Brazil. And the protocol was designed to provide the inclusion of the GCSPD testing and the radical cure of malaria Vivax with tafenoquine and the different regimes of primaquine. So trust involved 43 health facilities in 2 cities and more than 6,600 health professionals trained. And all the professionals they're responsible for the entire process and the diagnosis and to treat malaria in both cities. So for 1 year, the study database was fed more than 6,000 patients with malaria Vivax and other types of malaria. And we follow up also more than 100 hospitalization data occurring after the diagnosis of malaria with these patients. So I've separated some points to discuss with you and to present with you that I sense it is important to discuss and to present for the other corporates, and can be useful to the implementation in different settings from our cities. So we'll discuss a little bit about the TK and GCSPD test logistics and the training metrics that are used for the healthcare professionals, and the adaptation for the healthcare facilities about to receive and to distribute adequately the drug and the GCSPD testing, and a bit about the supervision and the pharmacovigilance that we initiate in the healthcare facilities. So first of all, about the supplies, the initial plan for trust was to maintain and to insert the supply, the TK and the GCSPD test insert and keep them with the routine supplies for the other supplies from malaria control program. And as you see in the workflow, the FMT received all the supplies firstly from the vendors, the donors, and we distribute that for CPEN also in Rondônia and in Porto Velho City. But all the routine of the distribution and the control of supplies was made by the municipalities and the state level control program of malaria. So it's important to emphasize that the team, that the research team was only observing that all the process, all the introductions and the process for the work process was made by the healthcare professionals on the malaria control program. About the training, it's another bottleneck for implementation. So it's important to know is the first contact they have with the GCPD testing and the new drug. So the training involve different professionals, and have doctors, nurses, pharmacists, laboratory technicians, health agents, microscopists, all present and working day by day in the malaria service. So all different work scenarios and all different backlogs from them. And we need to adapted some trainings from them and to transfer to them the knowledge to implement adequately the new tools. So the idea was to customize the trainings and for the implementation and both person training. We have person training sessions and also we have we developed the platform, a digital platform training to them. So here's the matrix of trainment. So we developed that in a manner to involve all the different professionals, adapting the content to the needs of the professionals, but we're trying to use the same materials that we designed with the Minister of Health, the Brazilian Minister of Health. It was distributed in all the healthcare facilities during the implementation. So here are some examples for our guidelines that we developed with them. So we had a lot of materials, including GCPD step-step guideline for the use of the biosensor and the new recommendations for the notification of the positive malaria cases, and also quick tables with the treatment schemes, including tafenoquine. It's important to say they have now to make the decision to use tafenoquine, 7-day primaquine for the primaquine or single dose primaquine in case of super or weekly primaquine in case of the treatments of the GCPD deficient patients. Another strategy was to develop a digital platform with 5-minute classes taught by our principal investigator, Max Lacerda, and that including changes in the algorithm for the treatment, detection and management of the hemolysis, and the notification of adverse events to the national reporting system, because it's very important in the phase of implementation of the new drug. So as you see in the table, we have a lot of tables to explain, and including the tafenoquine use decision for all the healthcare professionals, and it was shared online for them. Another important tool we have was to get the perception for the field by the Quality Trust researchers. Quality Trust was a qualitative survey made during all the process of trust, and we catch some perspectives and perceptions from the healthcare agents about the training and how they see the use of the new tools in the real life. So it was important to catch them this perception, and that professionals can show to us the weakness and the strengths of the trainer that we provide, and we were able to have more adequate feedback and to modify the training down to make the transfer of the information better for them. So with this, we're able to develop an adequate and more participative lesson plan for them, and also to develop a framework of training for these professionals. Also, the healthcare facilities adaptation was a challenge and a bottleneck for us. And another important phase was to prepare the health units to start the implementing tools after the training of the healthcare professionals. So first, it's important to understand the bottlenecks or difficulties they foresee in the insertion of the new tools. It should be considered that this is the first time that you have the opportunity to perform GCPD diagnosis in Brazil, and the use of the biosensor also. So the idea is, of course, it would be to influence the work routine minimal at the minimum possible, and to change the workload of them at the minimum also, to give them the opportunity to use the new tools with minimal change in their routines. It's important to note that they will not always find the best conditions to carry out the work, but they will often have to adapt what they have learned in the field. So it's important to know, and it's important to emphasize the field agents are the experts on adapt all the knowledge they get from the training in the work field. In addition, we designed with them the workflow of each type of unit that was involved in interest for the referrals and the operational basis for the diagnosis of malaria. So it's with the active participation of the healthcare professionals, and it was important to design and to insert each professional in different points of the service of malaria diagnosis and treatment.
Marcelo, you have 5 more minutes.
Okay, thank you. So other point was about the supervision and to maintain the quality of the implementation of health units. There as units carried out by the municipal secretariats and the quality control of the GCPD services. So we inserted that routine of the GCPD testing and tefenoquine in that routine of supervisions, and they have an electronic system for that. So we insert all the new tools in the electronic call for. Also was the first contact of the health agents from the world cities with pharmacovigilance strategies in the malaria program here. Here, the main point was to make clear the cause of hemolysis and to bring the clear concepts about GCPD enzyme and its deficiency. Many of other associations, many of them associating the hemolysis and dark urine with malaria, but they did not associate it with malaria treatment, for example. So it was cached during the quality trust, and we trying to clear their minds about that. And the electronic system also we started question regarding signs of hemolysis and beginning to treatment, and the return of the patients on the D5 to because it's considered a good point to catch the probable symptoms regarding to hemolysis. All patients also received a card with the treatment information and GCPD activity. In addition to the figure with the alarm signs for hemolysis. Unfortunately, this was not good acceptability for the patients, and maybe we may need to adapt that strategy and modify the template for the card for the future. Other data from trust was collected filling out the CVAC malaria, the electronic form, by the municipal healthcare professionals and downloading the FMT database. Then, as we had not contact with the patients when the inappropriate use of the tefenoquine or primaquine in relation to GCPD activity was detected, this result was returned to the municipal surveillance for confirmation and follow-up of the patients. So we generate a dashboard with this information, and if you could monitor the arrival data on a weekly basis and send them to the feedback of the inadequate treatments for the municipal surveillance system. And here's an example of cases in which there was prescription of treatment without GCPD testings, and we had tags in our database to favor the search and to look the inconsistency in the trust database. Another important point was to prepare healthcare professionals to advise patients about the new routines of malaria diagnosis, the new tests, hemolysis by antimalarials. And we made the curriculum available so the patients could read about the topic calmly at home and could also clarify this topic. This helps to engage patients in proper treatments.
Un minuto, Marcelo.
I'm finished. Finally, you have used the digital tools such as message apps to share cards and quickly videos that you support professionals wherever they were. All we had they can download that in the cell phone, have access to the material whenever they want. So the
Marcelo, ¿nos escuchas?
Marcelo, can you hear us?
¿Alguien más tiene problemas escuchando a Marcelo?
Well, can someone listen to Marcelo?
Okay. Gracias. Marcelo,
Thank you.
¿me escuchas?
Marcelo, if you can listen to us.
Bueno, igual creo que él iba a presentarlos un poco este estudio de
Well, I
cualidad
guess that he
percepción
will
de los
present quality
de los
trust
pacientes sobre y la
under the
importancia
patient's
sobre
perspective and health
malaria.
workers.
Así que le damos gracias a
So we thank Marcelo for his excellent presentation about trust. And now we are going to mention to the operational and to the national implementation, and we are going to give the floor to Cassio Peterka, who is in charge of Malaria Elimination Program from the Health Ministry of Brazil. We know that this can be real to be implemented by a country. We can see Brazil that has been a pioneer and has started the implementation program of tafenoquine and G6PD, and Cassio will talk a little bit and we will tell us where are we and how are we going, what are the next steps in such a big country and complex as Brazil. So Cassio, I'll give you the floor. Thank you.
Thank you, Jonathan. Can you hear me?
Te escuchamos muy bien y recuerda que puedes hablar en inglés o en portugués, como tú quieras. Adelante.
So thank you. It's always a pleasure being here in PAVE meetings. I'm here with Dr. Claudio Ribeiro and Dr. Gisele Rachidi with our national references in Brazil. Since we will have a translator, I will speak in Portuguese. I will share. Vou compartilhar minha tela.
I'm going to share my screen now. Okay, it's always a pleasure to speak to you about what we've been working on in the implementation of tafenoquine in Brazil and how we've planned including it in this process. I love to talk a little bit about the epidemiological situation of malaria in Brazil and how today we are doing at a threshold with a reduction where control is no longer split. We have to move on to elimination. From this perspective of elimination, we can see that Brazil has been a pioneer with the implementation of new drugs and treatments for malaria, like at the early 2006 when we implemented the use artemisinin, their derivatives in reducing malaria, PAVE falciparum cases, and advancing with the control of this disease, artemisinin products, and with the introduction of injectable artesunate, we had a drop in the number of hospitalizations and deaths, showing the leading role of Brazil over the course of the years in the implementation of new strategies and new treatments for the elimination of malaria that we can see very near at hand. And in this epidemiological situation, we have our plan for the elimination of malaria, where we follow a line here, not only with cases at the national level, but also distributed by municipalities and state for us to be able to move forward in 2035, no longer having malaria transmission in Brazil. Here's the issue of falciparum malaria, where we have a somewhat more ambitious goal, considering precisely the issue of resistance to artemisinin products. So in 2030, we should have eliminated this form of malaria in Brazil, P. falciparum. Considering this context, the main objectives in our program for elimination of malaria, this includes the importance of having new strategies like tafenoquine and G6PD. We continue to prioritize diagnosis and treatment, timely fashion, adequate treatment to promote actions, to promote and conduct activities for prevention control to be sustainable in the states and municipalities of the country. The municipalities where we've already eliminated, we have to avoid the reestablishment of malaria or reintroduction and to promote research and development. I believe that trust is a prime example of this partnership between the national program and academia, meaning that we are able to have the materials that are sufficient to back the implementation in a country as large as Brazil of major dimensions, which means that we have to have care, much greater care with any kind of strategy that's implemented here. So the situation in recent years here, when we compare 2009 to 2022, 2019, you can see a reduction in the number of malaria cases, but in the first semester, we have seen a reverse situation. We know that the climatic issues and environmental issues have affected the Amazon, and this also can be affecting these malaria cases. Although we have seen a reduction in the cases of malaria in recent years, it's a controversial issue because of the pandemic that we suffered here, which is the severe cases and deaths. So we can see here a promising scenario, not only epidemiological, but also structurally in a country, in Brazil, for us to be able to implement tafenoquine as a strategy, not only to accelerate the elimination of malaria, Vivax malaria, but also to reformulate and support this new view where we go from a program, a control program, and moving towards an elimination program. So here is a little bit of our falciparum malaria. Right, Vivax corrected himself. You can see here the concentration of P5X, especially in the far west of Brazil, in the Brazilian states, a higher concentration of risk for P5X and falciparum, with falciparum as well. So in Brazil, we have a situation where 30 municipalities have 80% of the cases in Brazil, malaria cases in the country. And for malaria falciparum, only 16 municipalities have concentrated them. The 5,500 Brazilian municipalities, 808 are part of the Amazon region. And of these 808 municipalities, only 304 have active transmission in the year 2022. This demonstrates the importance that we have for new strategies and how we can approach the epidemiological situation with innovative strategies, for example, the introduction of tafenoquine. One of our greatest problems today relates to special areas like indigenous areas and mining areas, pan mining areas. You can see this distribution here of cases, and I can see here that practically the half of the cases in Brazil in 2023 occurred in indigenous areas and mining areas, and these populations are ones that we have a major difficulty in adherence to treatment with them because of the cultural issues of the indigenous peoples and the Amerindians, and also because of the issues of illegal pan mining and all the issue that involves access to diagnosis and treatment in these pan mining areas. So we emphasize here that another important issue, which is tafenoquine, specifically for radical cure in these populations. So after having done the entire process, all this project and the trust with the results obtained over the course of the years with trust, we did a dossier. This dossier was submitted to CONITEC, which is the National Commission for the Incorporation of New Technologies in the Unified Health System, the SUS, where we do an assessment by specialists where we assess in feasibility, not only for efficacy and effectiveness, but also the cost-benefit analysis for new technologies to be incorporated in the national public health programs in the country. So when we presented this dossier and defended it, in addition to being cost effective with this implementation in Brazil of tafenoquine with G6PD testing, there was an important issue, which was namely you don't have a prospect of having a new drug for Vivax in coming years. So this meant that this emphasized the importance of the incorporation of a drug which is already there and which can be used, and it can be a feasible process for the elimination and radical cure of Vivax. So based on this report and this dossier and these results, in June this year, in 2023, there was a ruling that was issued that incorporated tafenoquine and G6PD testing in the SUS, the Unified Health System in Brazil. So with the incorporation, we were able to launch a process of bidding and acquisition for scaling up as oriented by the dossier for us to be able to do this implementation of tafenoquine in Brazil, plus G6PD. We could show that I saw the results presented by the other countries at the beginning, the research and studies in the first part of the meeting, and we underwent this. My team is available to support the other countries in whatever they need in their studies. Dr. Marcos Lacerda and myself were always available to make progress with this. The incorporation of tafenoquine is going to help with the acceleration of the elimination of malaria, but we cannot think alone on the issue of elimination in a single country. So considering the Americas as a whole, this becomes even more important to be well aligned and working together. Thank you very much. You have 5 more minutes. Okay, great. Okay, thank you very much.
You have 5 minutes.
Based on the practical issue with the scaling up of the implementation, we intend for the first semester to resume and expand to all the sites in Manaus and Porto Velho, including Cruzeiro do Sul and Acre and Tausuili in Amapá, because of the epidemiological situation. We could see an important issue, which is of support for these municipalities. So in this first semester in 2024, it would be we'd acquire almost 30,000 pills of tafenoquine, 200 pieces of equipment for diagnosis, and almost 20,000 strips for G6PD testing. In the second semester of 2024, this expansion would extend to 61 municipalities and 15 municipalities in Amapá, plus Amazonas and 21 municipalities in the state of Acre, and also all of the indigenous areas contained in these areas. So we would have almost 70,000 pills and more than 1,200 pieces of equipment with almost 70,000 strips, testing strips for G6PD in this for implementation in the second semester of 2024.
For the first half of 2025, we would have the municipalities in the state of Pará, 144 municipalities, 51 municipalities in the state of Rondônia, bearing in mind that we have already implemented in Porto Velho on that date, and the 5 municipalities in Roraima, meaning that we would be in a position to distribute another 95,000 pills or tablets, almost 95 or 90, almost 1,000 units of treatment, and almost 7,000 strips. For the second half of 2025, we would cover the remaining states in the Amazonian region, therefore covering the whole of the territories in the legally defined Amazonian region with the tafenoquine tablets, meaning that by the first half of 2026, we will be in a position to extend the exercise to all of the Brazilian territory. The idea being that by the end of the first half of 2026, all of Brazil will be using tafenoquine. To that end, accordingly, we have a procurement estimation for 2024-2026, and also a distribution strategy. And of course, we're considering distribution patterns in such a way as to prove more doable, not only for implementation purpose, but also considering the needs of the supplier companies. By the end of this whole exercise, we will have distributed almost 105,000 or 150,000 pills and thousands of diagnostic strips. So this is, in a nutshell, the implementation plan we have been working on, and I want to thank you again for the opportunity and for the ongoing cooperation with all of you. Thank you, Carlos. Well, thank you so much, Carlos, for
Thank
your
you for
wonderful
your
presentation. We wish you all the
presentation,
best.
and we
Best of
wish
luck.
you all the
And of
best,
course, we will
and thank
certainly
you
keep
for
on
all the
offering
support
to
that
the
you're
Brazil implementation
showing
plan.
in this Brazil implementation program.
I will now move on to a different topic,
Now I'm gonna
which is about how the government has been working
how the
together and
government
in
is working
cooperation with the
together with the
private
private industry.
sector
And now
industry.
we will
And we
talk
will be
about
hearing a little bit about
the supply
assuring
chain guarantees,
the
both for tafenoquine
supply
and
chain.
G6PD tests,
And
with
the panel will
Alison
include Alison
Nunes
Nunes, representing
with
GSK
GSK
Brazil.
Brazil.
He is
He is
the sales and
the
vaccine
sales and
director for
vaccine
GSK
director,
Brazil, and also covers
and
public
other
products for HIV,
input
etc. in Brazil.
as HIV
We
for
will also have
Brazil, and
Mr.
Vinicius Pereira,
Pereira, who is the
Echo
CEO for
Diagnostic CEO, the local
diagnostic purposes and the
G6PD
local
test
domestic
distributor
distributor
in
of
Brazil.
the test
They will
kit
talk
in Brazil. They will be
about all the
describing some
necessary
of the
steps
steps and
to
measures aimed
guarantee the
at
appropriate supply
ensuring
of these products in
the
Brazil and
ongoing efforts in
partnership
Brazil and
with
the
government.
cooperation with Brazil. So with that, I'll
Alison
give
Nunes,
Alison
you
the
have the
floor.
floor.
Alison, you have the
You
floor. You're
can
welcome to
speak
speak
in
Portuguese.
Portuguese
We
if
do
you
have
prefer.
interpretation. Yes, good afternoon. Well, first of all, I would like to thank you for the invitation for this event. It's a very relevant event. It is a good example of how to address public health issues and the public health agenda in a coordinated fashion, including not only the initiative on the government sector, but also working hand in hand with the private sector with a view to achieving a common and shared objective. GSK Brazil, of course, is also in line with the objective of eliminating malaria by 2025. We have extensively worked together with the Ministry of Health, and we have had some discussions with a view to ensuring proper supply and the advancement of the implementation plan that has been described. It is really important to say, how or describe how GSK steps into this scene, if you will. GSK is responsible for registering the product in Brazil and for supplying the product to the Ministry of Health. So as Cassio himself mentioned, we got a favorable decision by CONITEC, the council, for using this acute or for using tafenoquine in the acute phase of this very severe disease. It is important to mention to you that the product has experienced some evolution during the development process. Currently, the product is indicated not only for adults above age 16, but also for children with a body weight equals or above 35 kilograms. So that's an important element which expands and enables access to these target segments of the population. Another point on logistics and inventory management. Its best before date has been extended to 5 years, which is the current expiration date, which of course now allows the ministry to better manage its own inventory in an easier fashion. So all of these are relevant points. It's not just about supplying the product. No, that is not enough. There's more to it. So I thought I'd share this with you. As indicated in previous presentation, I think it is worth mentioning that in Brazil, recently, back in April, we had the approval of a pediatric formulation, the very first such approval for children as of age 2, weighing or with a body weight between 10 and 35 kilograms. So it is yet another therapy solution made available for malaria treatment. So that's another point for further assessment. And once again, GSK Brazil remains fully available to provide any further support as needed. And again, of course, we remain as a company fully available to keep on working with you so as to meet the criteria and principles contained in the implementation plan that has been described here earlier. And of course, I do so while again underscoring our commitment as a corporation. Thank you, Alison, for your kind words.
Thank you
And
very
also
much
thank you for underscoring your commitment to jointly working with us.
here between JSK and the government. Now, I give the
At this
floor
point,
to
I'll give the floor
Vinicius
to
Pereira.
Minister Pereira, or rather Vinicius
Vinicius?
Pereira, the CEO with Echo Diagnostica. Good afternoon,
Hello, it's a
everyone.
pleasure to be here in this seminar. I will speak it in my Portuguese and Spanish mixture. As you, I will try to speak in Spanish. An important point is that Echo Diagnostic is no longer a distributor. We have changed the name of the company. Another company bought our company at the end of 2021. We're part of SD. And this will be really very important, both for the Ministry of Health in Brazil as well as other Latin American countries, because this company has distributors in almost all countries in Latin America. And I believe that logistics will be much better now when this is in full scale. I am Brazilian, a Latin American, and I know that price is a very sensitive issue. And of course, we are talking about all our stakeholders, people from PAVE and the Ministry of Health. We know that that the cost will decrease as time goes by. I know that our production capacity is enormous. During COVID, the first antigen test was ours. So the first one was approved by us. So in Brazil, our automatized factory is up and running. We're just working for the national authorities' approval for full production in Brazil of G6PD tests and other rapid tests. So as I said before, as our friend from JSK just mentioned, we're very happy to be part of this change process in the diagnostic and malaria treatment scenario, and we really welcome these good news. So Jose will leave our mail available here in the chat for future reference or clarifications and questions. You can contact our distributor, and we can really go over the logistics and registration issues. If the company has no registration with the national authorities, we can support you. So this is it. Thank you very much. Thank you, Vinicius, for your words. Well, we will start now with our Q&A. Are there any questions from the participants? If you want to ask a question, you can raise your hand, unmute yourself, and ask your question out loud. Or you can ask your questions in writing, and I will make the question to our speakers in this panel. While we wait, I would like to ask a question. Cassio, a question for you. You mentioned the relevancy of the use of tafenoquine in indigenous populations, illegal mining communities. What is the main operational challenge you have? Of course, we understand that you are focused on rapid tests as the first step in intervention, but supporting an intervention and diagnosis for a longer time in these remote and complex areas is rather complicated with tafenoquine and G6PD testing?
Thank you, Jonathan, for that question. I think it is the kind of question where we
Esa es una
certainly
pregunta.
have to make progress, as it is the major bottleneck that we have in terms of access to treatment and diagnosis in these more remote areas of more difficult access. It is my view that establishing diagnostic solutions and treatment is part and parcel of the whole culture of elimination. So the kind of access we're going to be providing is an important part of the whole purpose. And we have been designing several different differentiated strategies to that end. For example, targeting the gold panning areas, for example, such as examples in the French Guiana, Malaquinte, Gugurema areas, for example, where we would ideally be able to mainstream strategies to reach out to the target population. And within the population, when I talk about a 7-day primaquine treatment or a 1-dose treatment with tafenoquine, of course, the compliance level will be much higher depending on what I propose. And we believe that making tafenoquine available is not itself the silver bullet. I often say that tafenoquine provides for a major change, sweeping changes, and it allows the local teams to stop for a breather, if you understand me, so as to give the program a new face, and therefore not be a program that is content with just control, but is ultimately aimed at eliminating. That means more access to tafenoquine so as to ensure proper diagnosis in these target areas. I mentioned the gold panning areas, but there are also the indigenous areas, which are an important element, not only as regards the cultural agenda, but also as regards access. It is also a duty that behooves upon us, as members of the Ministry of Health. We must provide healthcare. People who live in the Amazon region are entitled not to get sick from malaria, and that is something that we are tasked to do. And from a government perspective, we have substantial support from the current administration that we believe will help us make progress towards reaching out to these target peoples where they are. The issue regarding malaria is not just a public health issue, it is also an environmental issue, it is an economic and a social issue at the same time. So ensuring that these people will not get sick from malaria is ultimately a developmental issue for the Amazon region. It is also about sustainable development in the end of the day. Thank you so much,
Thank you,
Cassio, for those
Cassio.
remarks.
I also
I
have a
question to
for
Alison and
Alison and
Vinicius
Vinicius.
as well. In your
According
view,
to your
what would you
perspective,
say
which is
is
the
the most
greatest
important
effort if we
effort
should
that would have to be
choose
undertaken if you had or could choose one
one
type of
single
activity or some
activity
kind of
or initiative
initiative to ensure that
for
product supply
ongoing
be sustainable
supply
in the
throughout
course of
time?
time? Or the
Which would be the first
supply
step?
of the
Would
product?
that be local
Should we move or shift towards
production,
the local domestic
larger
production or
regional
ensure
volumes?
greater
I
regional
mean,
volumes on
what
demand so
would be
as
the first
to
step
make sure production is more
necessary,
interesting
or
for you, or simply
simply
expect the price to go down as a result of
lower
the
prices?
market forces? What do you
Which
think
is
is
the
the main
first
effort that we
step
could undertake so as
we
to
should
ensure that
take to make this
production
sustainable
supply remains
throughout time,
sustainable in the course of
following
time? Of course, we're talking about the
Cassio's
strategic plan
strategic
for the
plan?
next
We're
seven,
talking
10
about
years
7 to 10 years
ahead.
down the line. Jonathan, I believe that on our part, there are two very important issues. Our sales forecast 10 years down the line, and then with this general picture, we could try to lower our costs. It is really very difficult to work in this under these circumstances because the drug scenario is totally different from the diagnostics scenario. Diagnostics and drugs are two separate and different worlds. So I'm talking about diagnostics, marketing, that's my expertise, and pieces of equipment are the expensive part of our business. So if you have a reliable forecast, if you have a larger or longer prospect, we can really partner with the Ministry of Health, as is the case now currently in Brazil, for larger volume sales. That would be the number one situation.
Yes. Sounds great. Well, GSK has a long-standing experience in HIV vaccines, and we're now stepping into the malaria market and supporting the Ministry of Health in this agenda. I often say that the most important point in ensuring proper supply is predictability. In other words, we have to be able to rely on proper forecasts, as Vinicius indicated, so that we can schedule ourselves, program our efforts, while, of course, ensuring sustainable product supply in the course of time. So scheduling is absolutely proper to understand what the ministry's strategy is in mainstreaming certain types of medications. It is my understanding that more specifically for tafenoquine, considering the nature of the disease at hand, it is not a simple or easy disease to treat. It is a disease which we aim at eradicating and eliminating in the course of time. So we know all too well just how difficult predictability can be, especially considering that we're talking about a different type of therapy and innovative treatment. I have substantially and extensively talked to Cassio about this issue on different occasions. But again, predictability is a key factor to ensure proper product supply. If we do things in a well-planned manner in advance, we will certainly be able to ensure proper product supply, regardless of whether production is domestically or abroad. So that, to me, is the most important point to ensuring product supply. Thank you so much.
Alison. Now, I would like to ask Marcelo a question, but of course, we have Adelio Pereira present in the chat with us, and he was part of the presentation as well with Marcelo. Adelio Pereira is here with us. I would like to ask you, Marcelo, considering the importance of this alliance between private industries and devices and government, we also see that there is an importance in the partnership and alliances of manufacturers and governments. Marcelo, what is the participation of researcher teams in the development of these implementation plans and the Ministry of Health in Brazil? Marcelo, what is this interaction?
Right, thank you for the question. I think it is important to highlight that our interaction started way back at the commission's level. We didn't really start from scratch. There's a very well-established malaria treatment in the Brazilian Amazonian region, which involves and enjoys very close channels of communication between academia and researchers and government players. And we have tried to introduce as few changes to the plan as possible. As implementers and facilitators of the effort to implement new technologies, including the educational component, we have actually optimized the means that had already been made available by the Ministry of Health through the local secretariats to be able to implement the effort. And that is why it has proved so successful, as indicated in the figures in the recent past, showing that all of the effort that was undertaken is something that ultimately stemmed from the previously existing malaria program and the relevant agents. I'm sure Delio can say a few more words about it. Yes, of course. Good afternoon, everyone. Cassio said something very interesting when he referred to these two novel instruments, the G6PD testing and also the tafenoquine. The two have been used in and of themselves as drivers of innovation to treat Vivax malaria or Vivax malaria in the past 60 years. And of course, for those of us who work or those who work at the field level, the local staff and agents, people who, of course, work in remote areas where access is very difficult and where logistics is very challenging in terms of making medication available. When we introduced these two medications, at the beginning, there was some reluctancy, some resistance, because people thought, well, a new drug, more work. But the learning curve, however, and this, by the way, has been assisted by our qualitative research, indicating that the fear has been very swiftly overcome as we were able to work more closely with people who are capable of conveying this new knowledge in a quick manner to the target population and do so in a very accessible and friendly manner. The research in Brazil and also in Porto Velho, where we have a research center, we have worked very closely with the ministry and the municipalities so as to remain available to provide this kind of response, not only during the training modules, but also during the implementation in the course of time by means of WhatsApp groups and social media network, using short videos, for example, to answer questions received from all of this network of people where we have introduced the two treatments. So that has managed to very quickly reverse a sense of fear of a new technology. And we were able to change that to a much more positive stance in terms of the high and very positive expectations regarding the results from the use. So this partnership between academia and the field players has proved very, very productive in our implementation efforts in Brazil.
Thank you, Delio and Marcelo. I don't know if there are any other questions from the participants. And once again, you can unmute your mic. Leopoldo, yes? Please introduce yourself before you take the floor. Hello, I'm Leopoldo Villegas. I'm the Senior Malaria Technical Advisor of MMV, Impact Malaria. Thank you for the Brazil team. Great to see this level of coordination in all of the sectors. My question is an open question mark because what Brazil has achieved has taken time. And we will see a lot of countries running towards tafenoquine, but we need to make a very quick market assessment and identify needs. Cassio has just mentioned special groups and special communities, but I believe that we will start talking about implementation in remote communities, indigenous people communities, mining communities. So, I mean, we have to really tailor our initiatives to these populations. The massive use of drugs using G6PD testing and tafenoquine, of course, this implies forecasting changes, as Alice had mentioned, prospects and forecasts that will be made 1 year beforehand. So my comment is just input as far as forecasts are concerned. And 2023 is over. 2024 will start at full speed. And we will really need to join efforts amongst all of the countries here. And the ministries of health will really need to focus on numbers, figures. Thank you. Thank you, Leopoldo, for your input. Yes, especially since we are, all of us, waiting for WHO's recommendation on tafenoquine and G6PD testing. And all the countries are really waiting for this decision to make progress and implement all of these new tools. And of course, everybody is eagerly waiting to start using tafenoquine. And of course, we know that there are many challenges, as we've seen in the Mesoamerican session. Of course, it'll be a fantastic channel that we will need to focus on and try to overcome with the support of PAHO, with the strategic fund that will support us in all of this process. But of course, as you're saying, the key question here is forecasting, planning, previsibility. Jonathan, one comment, and I forgot to make one comment. Regulatory requirements, the legal framework in different countries varies. And I mean, so we need to consider that the legal arrangements, not only purchases, but also registration, red tape. And yes, definitely, we need to see which are the countries that will be able to make these purchases, how we can support them in registration processes, because of course, as you mentioned, each country has a different process. Vinicius? An important comment here is the following. Maybe with the pandemic, and maybe 2 or 3 years before, we suppliers saw globally, especially in Brazil, that when ministries of health want to be quick. Things get done. In the case of Brazil, COVID registration paperwork was very fast, 15 to 20 days. In Brazil, it takes 4 to 6 months to make all the filings and registration paperwork. So everything that has to do with production, talking about diagnostics, rapid tests, test strips are very fast. Strips are manufactured very, very fast. So there are no problems with rapid tests. The most difficult part are the meters. We need a little more time with meters, which are 3 stages. First, registration. That is why it's a top priority that a country that is interested should contact us directly to support them with registration paperwork and suppliers, because this really takes time. Second, try to make some forecasts. We don't need too specific forecasts, but just a ballpark figure, because we're talking here about Brazil. How long have we been talking with Brazil? 2, 3 years? Am I right? I mean, and I understand your concern, but things now are going at full speed, and we have the support to do it. Great. Thank you. Thank you, Vinicius, for your input. Are there any more questions, Alison, or can we wrap up?
No additional comments.
Okay, so we can continue. Okay, then. Thank you all for the participation in this panel on the Brazilian experience. Thank you very much, our speakers, skipping lunchtime. And thank you very much for your input and comments. Now, we will proceed with our next session on reaching special populations, challenges, and efforts. Sheila Rodovalho from PAHO will share her experience with this type of special populations. Thank you. Thank you, Sheila. Thank you, Jonathan. Thank you very much.
Good afternoon, one and all. My name is Sheila Rodovalho. I'm PAHO Brazil National Malaria Infectious Diseases Technical Officer. The Pan American Health Organization. I was invited and accepted the invitation to work as the chair, the moderator of this panel, reaching special populations, challenges, and efforts. This panel discussion today is extremely relevant, this discussion, because it's one of the main bottlenecks for the elimination of malaria in the countries which have these vulnerable populations, special populations, such as indigenous people and pan miners or garimpo. First of all, I'd like to pass the floor to Dr. André Siqueira, who is a researcher, a professor and researcher under the Institute of Infectious Diseases at Fiocruz, Oswaldo Cruz Foundation, and he also is a member of the Technical Advisory Committee to the National Malaria Program, in addition to being a great friend and partner in these discussions pertaining to elimination of malaria in Brazil. Dr. André Siqueira, please feel free. You have 15 minutes for your presentation.
Los colegas.
Hello, I will speak in Spanish. Can we share the screen with my presentation, please? One second. Thank you. I will talk about our experience in Yanomami indigenous peoples communities, which are the challenges and responses. And I will talk about the lessons learned and opportunities. Many of you probably know that in the beginning of this year, in January, a public health emergency situation was established in Yanomami communities, which includes the states of Roraima and Amazonas states in Brazil, and Yanomami peoples also crossed over to the border in Venezuela. For several years now, the situation was rather difficult, but with the increase of mining activities in Yanomami reservation territories increased, the situation got worse. You can see on screen the red dotted areas that represent active mining activities. We're talking about a 30,000 Yanomami population, and all of the illegal mining activities, the disruption of communications, there was no access to any point of care or health facility. Well, these are the figures: 31,000 Yanomami community members scattered in different communities, almost 376 communities, some very large, some smaller, some in closer locations, others very remote. Look at the malaria reports at Yanomami communities. Underreporting and underdiagnosis is rampant in this area. 15,000 cases are probably less than half real figures in the region. One of the activities in the mission, this is a former indigenous community agent and a nurse. We performed an oral exercise. I'm sorry, I think our speaker is muted. Okay, this intervention took place in a period of time in which they were not reported deaths, but 10 possible malaria deaths were reported during this period. We won't be able to confirm that these 10 deaths were malaria cases, but the clinical characteristics were compatible with malaria. These deaths took place because of lack of healthcare services and diagnosis, and we sometimes use helicopters to transport patients, but each helicopter can only carry 8 patients at a time. So it's really a minor possibility to support these communities. Well, these are the effects of illegal mining activities in these indigenous populations. These are the number of reported cases in the year 2000 and 2022, with greatest cases of falciparum malaria. Remember that 10% of cases less than 10% of cases in Brazil are falciparum malaria. And take a look at these images. Our president declared that there was a public health emergency situation. There is a response underway with an increase of reported cases, which is not necessarily an increase in transmission rates. And I will tell you in a minute what the situation is, including areas in which we had no data whatsoever because there was no facilities or healthcare infrastructures. With 18,000 cases till June. much higher rates if we consider yearly figures with more than 30,000 reported cases, which still considers underreporting.
Aún son por microscopía en el territorio, cerca de
Most
90.
diagnosis, that is 90% of diagnosis, are made by microscopy, which is now slowly changing thanks to rapid testing. But of course, we need to increase coverage of rapid testing. And take a look at the activities as an answer to the emergency situation. So, we have Wakau community at Surukuku territories. We have 205 tests provided. 80% of the positive tests are falciparum malaria, which is a very terrible situation, considering which are the possibilities of implementing a pilot study with 3 massive treatment rounds with AZT to reduce falciparum load in blood stages. So there is an absence of diagnostic and treatment in different communities with very long infection periods, with more than 50% in the gametocyte stage, with the prevalence to TDR positive results from 0 to 60%, and also falciparum malaria from 3 to 80%. Of course, underreported and unregistered deaths and the inability due to logistic and resource issues to implement ongoing and continuous treatment initiatives in the territory. As Cassio mentioned, when we talk about falciparum malaria, well, things are even worse because most falciparum areas are located in these mining and Yanomami indigenous peoples communities, with the compounded effect of this type of malaria. Incidentally, miners and indigenous peoples populations have similar characteristics in terms of the demographics of these communities. These are vulnerable communities. Most miners that perform illegal mining activities are also vulnerable to this situation. They're also victims, if we can use this word. So, nutritional malnutrition, other influenza or COVID outbreaks, and other diseases, onchocercosis, that are present in the territory, and of course, violence, which is rampant in the area. But of course, by the same token, considering this terrible and vulnerable situation, the public health emergency should be perceived as a situation in which more long-lasting initiatives should be taken, from the possibility of implementing initiatives to eliminate malaria, that is, interrupt illegal mining activities, improve access to healthcare with local workers, with voluntary workers, local community members. And there is a local will shown by new public health administration officials and Yanomami representatives, which should really establish the goal of eliminating malaria in these communities. There have been other situations in which malaria was almost eliminated in this territory in the past, so it is possible. And now we are faced with this situation with new, powerful tools that could be the possibility to eliminate malaria in this community. One of the situations we should consider is mass drug administration. In emergency situations, and also considering what the WHO recommends to reduce the burden of the disease and transmission, and also in areas in which this would be an answer for elimination. Andre, you have 3 minutes. Of course, tefenoquine was approved and is available and should be a top priority. We know that G6PD deficiency in this community is very low. So, if we can use something that is more powerful and efficient, we will be able to reduce relapses. I believe that the emergency situation that strikes this community is such that tefenoquine would be the quick and perfect answer to redress the situation. Of course, there are other possibilities. Other answers are under study, but we should consider the possibility of anti-malarial chemoprophylaxis in these communities, indigenous peoples, mining communities, to reduce parasitemia in general. There are good experiences that could be copied from Southeast Asia and could be implemented in South America. And of course, what about other technologies as a monoclonal antibody against falciparum malaria, which is maybe an answer for remote and difficult access communities that need wider protection, or populations that are vulnerable from a healthcare and political perspective. Well, this is what I wanted to share with you today. Thank you very much for your attention. Thank you, Andre. Now, I give the floor to Ivan Cardenas, head of the National Malaria Program from the Ministry of Health of Colombia. Mr. Cardenas will talk about operational challenges of malaria in border areas. Dr. Cardenas, you have 15 minutes. Thank you, Sheila. Good afternoon. Can you raise your volume, please? Okay, Sheila, yes, thank you. Could you share my screen, please? There you go. Thank you very much. Okay. Thank you, PAVE, for the invitation. I will talk about operational challenges in malaria in border areas, all up to the elimination. And think about the implementation of different projects to eliminate malaria in border areas, which is not only a problem in Colombia, but is also a problem in other border countries. Let me put this into context. Colombia has a very long border area with a lot of irregular passages, more than 2,000 border kilometers with Venezuela, 1,600 kilometers with Brazil. We have a border area with Paraguay with the massive passage of migrants towards the north, towards North America, with the displacement of hundreds of peoples. And we have our border area with Ecuador and Peru, as well as a border area with the ocean. Well, migration is one of the problems we need to deal with, and we have identified 4 different types of migration waves. We have the regular migration, that is any foreign alien that enters the country legally with entrance registration. And we have the irregular migration, people that come in with a legal status but stay longer than the allowed time for legal stay in the country. They stay in the country working or doing something else. Of course, we have the seasonal migration. These are migrant flows that have 2 nationalities and come and go. In the previous presentation, this topic was mentioned with this type of movements in the border area with indigenous peoples that have subsidies or incentives in Brazil and in Colombia. So they stay some months in Colombia and some months in Brazil, which is also the case in my country with Colombia and Venezuela, where, of course, people come and go and cross the border because these communities live on both sides of the border. And of course, this is a new type of migration, which is the migrant that are in the country in transit. They arrive in Colombia just as a stopover before they migrate to the final destination, which generally is the United States. Most migrant routes are the following: migrants from Asia or Africa that enter South America through Brazil, Bolivia, or Ecuador, and migrants that enter from Brazil, enter through the Amazon border, which is the border that we share with Brazil in Leticia, and then enter the country. We also have migrants from Chile, Peru, and Ecuador that enter through the southern part of the Pacific coast in Nariño and travel north all the way to the northern border with Panama, where there is a maritime crossing. So they enter Panama as a stopover towards the United States. We also have migrants from Haiti, Cuba, and other Caribbean countries. They generally arrive in Venezuela and then come to Colombia through the border we have with Venezuela. Colombia is a stopover, and these migrants that arrive in Colombia all go towards the northern border in Colombia, towards Panama and Antioquia. Well, take a look at the main migration destinations that stopped over in Colombia. They arrive in the north of the country to an important harbor at the Antioquia and Choco states. And according to the last report of the High Commissioner of the United States for Human Rights, more than 330,000 people have crossed over through the Darien jungle. And these migrants in transit arrive in Panama through Darien, which is a jungle area in a very dangerous area. It's a very complex area, and people get malaria or pass away in this Darien Gap, and others reach Panama with malaria symptoms. So if you take a look at these migration waves and look at the different hotspots in Colombia, which correspond to the migration waves. Take a look at the map and take a look at these hotspots, which are totally in agreement with these migration flows. There are 4 hotspots that, of course, are located in the migration areas. The first is the Pacific Coast hotspot, with 52% of malaria cases in Colombia. The second hotspot is Urabá and Bajo Cauca and Alto Sinú, with 36% of cases and a sharp increase of reported cases. Now, in Orinoquia, we have the indigenous populations that cross over from the one side of the border to the other one, from Brazil to Venezuela, back and forth in the Amazon region. So they get malaria, or they all already have malaria and cross the borders in these 3 countries. So what is the situation of malaria in Colombia? We have 84,689 reported cases in Chocó, which is the border with Panama, and migrants arrive in our country and cross over to Panama to go to the United States. In Nariño, in the border with Ecuador, with one of the highest reported cases, 7,400. In the north of Santander, populations that arrive in Colombia from Venezuela for healthcare and medicines, and in other states that you can see on screen. Now, let's consider the determinants of each situation. And the relationship between malaria and migration waves is really very complex. And of course, there are some determinants that increase vulnerability of risk of migrants of getting malaria, since social and economic conditions in the region are very vulnerable with different determinants. And malaria controls vary in these communities with different degrees of healthcare and diagnostic access. So in Antioquia, there are 300,000 persons have crossed the border in North Antioquia. And look at the number of migrants that cross in Antioquia. So it is really very difficult to identify asymptomatic malaria patients or malaria patients full-blown. We do not have round figures. We have estimates. Dr. Cardenas, you have 5 minutes. Yes, I will finish in a minute. And the problem with migrants arriving in Colombia, those that arrive and stay illegally, they have no possibility to access healthcare systems. So diagnosis and treatment is really very complex because since they are illegal persons, they are not registered in the public health system. And of course, we have the underreporting issue. Okay, so what is the current situation? There are many difficulties to guarantee treatment and diagnosis access to these vulnerable migrant populations that go through our country. We have identified difficulties with drug access. Our drugs are free of charge in Colombia, but in these areas, we have come to know that these free of charge drugs are sold to users. We're talking about maybe illegal drugs. We do not know which are the drugs that are offered to these peoples. In these border areas, there are different difficulties with treatment schedules in the border with Panama. Panama has a different schedule for malaria in their country, which is very complex for follow-up. Prevention measurements as tents that can be used is restricted. We still haven't identified anti-malarian resistant populations, but it is a risk that could emerge. This triggers, of course, in these vulnerable areas, many cases of in-transit persons that that do not have access to appropriate treatment. And of course, there is a terrible problem as far as timely diagnosis and treatment for these peoples. And to conclude my presentation, what we would really need, and we are currently working on, is to have a strategic border plan that should include other authorities, NGOs, as a regional issue. This is not a country issue. This is a regional issue for border area countries, and we need a comprehensive plan. Of course, we are really lagging behind with diagnosis, treatment. We do not have a diagnosis network for the timely identification of cases. We should distribute rapid tests with voluntary support. But I think that this is a task we should focus all our efforts on. Of course, still much needs to be done. And we should really try to fulfill the need of implementing a joint initiative using radical cure with tafenoquine that would be fantastic to overcome the vulnerability of these migrants that spend just a couple of days in Colombia and then keep on moving in other countries. So I believe that a joint effort in the region should be made to support these migrants.
Thank you so much, Dr. Ivan Cardenas. So for the last presentation,
Christian Terry, que Dr. Christian es coordinador de la estrategia de malaria y otros metaxénicos de Jerez a Loreto, Administración Regional del Departamento de Loreto, Perú. La sesión tem el título de Enfrentando la malaria pediátrica en el Perú. Dr. Christian, por favor, 15 minutos.
Buenas tardes, doctora Robaldo y a todos los colegas. Un saludo desde acá de la región Loreto.
Hello, good afternoon. Thank you very much. Thank you. Thank you for the opportunity. I will talk about tackling pediatric malaria in Peru. My name is Christian Carey. I come from Loreto, Peru. First of all, I would like to share with you the fact that Loreto is responsible for more than 90% of malaria cases in the region. Unfortunately, all of the cases in Peru are located, unfortunately, in Loreto. So current malaria cases, according to the different stages in life, as you can see, this year in 2023, we see that 58% of cases in Daten del Marañón province, with the highest number of cases, 47% in Loreto, and 42% in Alto Amazonas province. That is, more than 50% of cases on average reported in Loreto are of children below 11 years of age, from 1 year to 11 years of age. When we break down by species, Vivax or falciparum, there is no difference apparently. Nevertheless, there are other provinces as Ramon Castilla or Requena with less cases, Ramon Castilla in the border with Brazil, with only 32% of cases reported are children cases. So within children in Loreto, we have broken down this category into age groups from 1 to 5 years of age and from 6 to 11 years of age. In the group of children of 9 to 5 years of age, Pastanza and Andoas, you see that they represent 57 and 61% each. And in the province of Daten and Marañón, we have high indices. Look at the incidence rate per 1,000 inhabitants, which is the indicator in our country. We're talking about 674 cases reported in Pastanza district. Only children. So it is a tremendous figure, out of which 14 districts with the highest case percentage in these two age groups. We could eventually think that, considering the fact that most patients are children and there's a high risk of having complicated cases, we should focus on our hospitals. But take a look at this chart and see where these children are seen. More than 80% of these children are handled in first care facilities and points of care with only technical personnel available, a nurse for most part, and most just technicians, a lab technician. And look at the point of care that has had more patients at the Corrientes River in Villa Trompeteras, with 20, total of 90 cases, 443 children. And these are first level, first care facilities. In Loreto, in the National Hospital in Loreto, only 6 children. In Iquitos, 8 children. In Urimawa and behind Amazon, 7 children. So the 3 hospitals in yellow down here, hospital in Loreto, hospital in Iquitos, and hospital in Urimaguas, had less children compared to all of the children that went to the points of care where they were seen. Going over death rates in these last 7 years, ever since the implementation of zero malaria in 2017. In 2017, 7 deaths were reported out of 25,000 reported cases. 7 deaths. In 2018, 4 deaths. 2019, 5 deaths. 2020, incidentally, this was when the pandemic started. I guess this is a under registration of deaths, no deaths registered, but nobody went anywhere in 2020. So we realized that when nobody goes anywhere in Loreto, we have less malaria cases in communities. And after this first year with no deaths in 2020, in 2021, 6 deaths, still during the pandemic. 2022, 3 deaths. 2023, where we focused on training for technical personnel and community agents, we fortunately had no deaths, neither adults nor children reported deaths in 2023. So what have been the different initiatives implemented in these last 8 years? We've realized that the highest malaria burden is with children. So our concern, and I want to thank the support that we have had from the Ministry of Health and PAHO with the strengthening of community agents and all the initiatives that have been implemented in primary care. We have 392 points of care in the region. Nevertheless, there are communities in which, due to remoteness or difficult access, there are no healthcare facilities. So I'm talking specifically about 3 provinces, Daten del Maranhão, Loreto, and Alto Amazonas. So in these 3 provinces, what do? We train community members. We call them community agents, community health agents. We train these community agents so that they can use rapid testing, and we also teach them how to provide treatment. We have used validated methodologies with PAHO, with fact sheets and information sheets, so that they can very quickly identify patients and treatment, even though in my country, community agents are not allowed to provide treatment. So we have better supplies. Last year, we encountered some difficulties, but these difficulties have been overcome. So we have guaranteed our treatment till the first semester 2024, and we're trying to overcome screening in malaria. With our malaria elimination plan financed by the Ministry of Health in Peru, we're currently implementing cluster brigades in focal areas and hotspots for an ongoing search of malaria cases. So this is what we're currently implementing, because there are many primary healthcare facilities that have children with malaria. Which are the challenges? Well, to keep up our response capacity in primary care in remote and border areas. Unfortunately, these remote areas have no healthcare professionals, but rather have a type of professional that will work for 1 year only, and then they go back to their hometown. So turnover is permanent in these areas. When we hire somebody to work in these remote points of care, we train somebody, but after 3 or 4 months, this professional leaves. So the challenge is how to train somebody that will stay there. And the other training is the supply and follow-up of our community agents. This is very expensive. We need to go to these remote areas, train community health agents, and if there is no follow-up, they will start doing something else because they have to make a living. Of course, these community agents need to make a living, and if you don't provide them the appropriate supply with drugs and diagnostic tests, they will stop doing their job and do something else. And the other thing is that, and I listened to the colleague from Colombia and Brazil that mentioned this earlier, the difficulties that we have in the Amazon region is to be able to guarantee ongoing treatment. This is very complicated. Patients interrupt patient treatment and only comply for 2 or 3 days. Now with Primaquine, they don't take it. They simply don't take the pill. So this is a terrible challenge. And now these cluster brigades, they stay on site in communities so that we can really focus on compliance. So this is what I wanted to share with you, and feel free to ask any questions. Thank you, Dr. Christian.
Please, if there are any questions for the 3 panel speakers, I believe now is the time. It's an important time for discussion at this time in approaching these special vulnerable populations, migrant indigenous populations, and children. If anyone has any question or comment, I can see here that perhaps some of the participants just raise your hands and I can check. Meanwhile, however, Dr. Andres Siqueira, I can see that I'm going to ask a question for each Dr. Andres Siqueira. I can see that the effort in the Yanomami emergency still persists. This emergency situation with the Yanomami people. What do you assess in all this process, this health emergency in the Yanomami people? What would you target efforts for us to be able to work with these indigenous peoples? That is a great question. I think there's several different channels. The challenges rather, I believe that we have to, there are 2 focuses. One is to establish, or 2 targets. We should have ongoing, sustainable, continuous activities, which are in care, healthcare, in a more comprehensive and integral way. In parallel with this, but I think that there is an emergency concerning the need to reduce the number of cases and to promote this path to elimination of malaria. So I believe that it's an opportunity based on the declaration of the emergency, because it's an area where we can demonstrate the possibilities for action to eliminate malaria in an area with these characteristics. So I would have a comprehensive program with a vector control program, patient care for cases, malaria cases, and with a view towards elimination. So treatment, mass treatment in some of these areas, prophylactic treatment in some of them, considering other tools as well. And I believe that I'm going to emphasize again what I already said. I'll say it again. The priority area for implementation of tefinaquine. I think it is the Yanomami territory is a priority area for tefinaquine. Thank you, Dr. Andre. We have several questions here, and I'll turn the floor over to Jonathan, after whom Alberto and Dr. Leopoldo. So Jonathan,
Primero que yo,
Estava
así que le cedo
primeiro,
la
porque
palabra.
aqui me
Sí.
desculpa, porque aqui não tem a ordem.
I apologize because I don't have the order here.
Está bien, doctor Jonathan. No problem whatsoever. Okay, just very quickly, more than a question, I would like to make a comment about the different country situation. I believe that this call for attention, I mean, these presentations really are looking for a cross-cutting approach in the search of solutions of problems as the ones that have been mentioned today. Malaria is just part of the equation of these vulnerable communities. It's just one public health component. In Brazil, illegal mining, migrant communities, but we also see this in Colombia, environmental damage, and the need to partner with the Ministry of the Environment, Labor Ministry, Education Ministry. These presentations are essential to understand the real need for cross-cutting intersection. I just wanted to make this comment. And other than that, I wanted to talk about the border situation and the need to really look at this as a regional issue.
Thank you, Dr. Alberto. Jonathan, please.
Thank you, Sheila. Two questions, one for Christian. Christian, I don't know if you have some information on the recurrence percentage in these populations. This question has to do with a different challenge. What about the current presentation of the oquinolone? We at MMV are currently working for the pediatric presentation. And what about the new pediatric presentation of drugs? What do you think about children management? And for Ivan, two questions. When you talk about the standardization of different schedules in border countries, could that be possible to standardize strategies and massive screening strategies? Not really massive, but migrant population targeted screening practices and really having a standardized schedule, because these migrants go from one country to the other, and which are the strategies that we could use?
Por favor, Dr. Christian, Dr. Ivan. Dr. Christian, primeiro, por favor.
Gracias, gracias.
Thank you.
Sí, realmente,
Yes. We do not have any specific information on reactivation of cases in children. This is one of the assumptions that we currently have. We are currently performing interventions. We see children that become infected. I mean, no, this is not the word, that present a recurrent situation. So one of the possibilities is that they are never cured due to two things. First, because they do not end the 7-day treatment. And second, because we have the hypnozoites that are still in the body. The hypnozoites are still alive. So in some areas, in Cayetano area, we have found interesting figures of the fact that there is no radical cure. So for us, this is a fantastic option. But this is only available from 16 years above. So Jonathan was talking about other options as aminoquinolone. You have seen that 60% of our cases are children. So we really need an option to see how we can deal with this situation.
No te escuchamos.
Intentar así a ver si me...
Así. Okay.
There you go. Thank you. Can you hear me? Yeah, great. Well, schedule standardization, what we have seen in the border with Panama, we use in Colombia a very conservative treatment schedule, Primaquine, 14 days. And in Panama, it's for 7 days. So some migrants wait to cross the border. I mean, they know they have symptoms, malaria symptoms, and sometimes they wait because they know that the schedule is shorter. On the other side of the border, we use Primaquine 14 days. So what we need to do is to really standardize these schedules. And Panama is, of course, interested in the use of tafenoquine. And when we talk about massive screening techniques, well, in Colombia, we're really very much concerned. And we do not have a good diagnostic network. These migrant routes have no support networks, or these patients are referred to community centers. And what we're trying to do right now is to strengthen or create a voluntary collaborators network in this migrant area to strengthen our capacity for diagnosis, rapid testing, and of course, points of care to guarantee access. But of course, we're not thinking about a specific screening strategy, but rather have points of care in these areas with voluntary collaborators. Thank you, Dr. Cardenas. We have 8 minutes, and then we will start with Dr. Villegas and Roberto Montoya for a round of answers by the panelists. My question is for Andre, a very interesting, Andre, what you mentioned. And I would really try to talk about this as a malaria specialist, as a physician. We have an outstanding debt. When I see such high positive rates, I wonder, why are we not more aggressive? Why don't we finish 3 cycles? Why can't we be more aggressive and focus on all the different vaccines and anti-malarials, at least in 4 visits? Try to massively treat these remote communities. These communities have very specific characteristics, especially the Yanomami indigenous peoples, but we should try to focus on a massive treatment that will have maximum coverage with Yanomami community representatives that speak their language, their community representatives, chiefs, to try to really deal with malaria and other parasitic diseases. Of course, we know that the illegal mining will come and go, but we need to focus on initiatives that will strengthen our position and try to fight against those that maybe are responsible for the dissemination of malaria. Sometimes fighting against these illegal miners is not the answer. Maybe we should collaborate with them and see if we can identify opportunities with which our illegal miners can also be served and can also be included. Because if we still have the parasites circulating, we won't be able to solve the situation.
Yes, thank you very much, Dr. Montoya, please.
Thank you, Sheila. I would like to congratulate you all for the fantastic presentations. It is really difficult to answer all of the questions. Each topic brings up hundreds of questions, but you focused in the agenda on 3 essential topics, and the quality of the information here has been outstanding. I would like to make a comment and a question. When thinking about the 3 presentations made so far, something that is really common to the 3 presentations, Christian mentioned the fact that in spite of the fact that in Peru, I don't know which is the percentage of malaria that is diagnosed by community agents. You mentioned that community agents cannot administer treatment. It is not included in the legal framework. And in Colombia, we have talked about the border area situation, as was the case with Andre in the Yanomami region. These three topics have one common thing, which is diagnosis and treatment on an ongoing basis in these communities. And this, of course, has to do with improving public policies and country flexibility to give diagnosis and treatment decisions in community participants, community stakeholders, and representatives that could really work and really make the difference, considering the possibility of making rapid tests available, drugs available in all of these situations, trying to increase the number of rapid tests that countries are using and buying, and increasing drug availability, trying to really implement plans so that community representatives have access to diagnosis and treatment. There is no other way out. If you need to walk just 1 hour all the way to the point of care, I mean, you just don't want to go there. And just one reflection that is common to the three countries. Christian, what is the proportion of falciparum malaria? I congratulate you, and great study of children population. What is the falciparum malaria rate? Thank you, Dr. Montoya. I give the floor to Dr.
Thank you, Dr.
Andre,
Montoya. I'll give the floor to Dr. Andre, followed by Dr. Ivan, and then Dr. Christian,
to wrap up
and
the
then
session.
for my colleague for the final wrap-up.
Thank you so much. Leopoldo, I agree with what you're saying 100%, because we need to be more aggressive. There is no way out. We need to be more aggressive with our medication, which is the only tool.
Doutor André, no estamos te escuchando, André.
You're muted, doctor. I also agree with the fact that, yes, we need a broader approach, nutrition, education, and it needs to be more cross-cutting in the emergency response. And I agree with what you have said, of course, the challenges of identifying how we can provide sustainability to all of these initiatives, considering other health conditions to keep transmission low and deal with elimination, as is the case with Suriname and other non-malaria conditions. Of course, this is a challenge. We need to make access easier and more sustainable. Thank you, Dr. Andre. Dr. Ivan?
Thanks, Dr. Andre. Dr. Ivan now has the floor, please.
Thank you. I totally agree with what Roberto mentioned earlier. There is an historic debt in our country, and there is something new that we have mentioned in our meeting. Today, a piece of legislation was passed for the use of voluntary collaborators. This is an important function for malaria, voluntary collaborators. It is part of information in the website for input, debate, feedback, that is, provide answers for the treatment in Colombia. Voluntary collaborators definitely need to be part of the equation. They have to be part of the answer. And we are focusing on the migrant populations, illegal mining communities, and indigenous peoples. Of course, the capacity of different healthcare facilities are really unable to cope with the demand. So we need to include other possibilities. This has been another possibility in the legislation. In 8 days, we will pass this legislation that will really give the legal status to the voluntary collaborator. This is the challenge for 2024. Thank you, Dr. Cardenas. Dr. Carey? Falciparum malaria cases in children is 34% of all reported malaria cases in children. But some districts have even 40% of falciparum malaria patients, but the average is 35%. Thank you. Thank you very much, Dr. Carey.
Thank you very much, Dr. Christian. It gives me great pleasure to bring the session to a close, as Dr. Montoya indicated, with many more questions. And we believe we actually should have more meetings, more panel sessions about the target and vulnerable populations. We should actually work on and design more policies targeting the target populations. As I said earlier, it is one of the main bottlenecks we face in eliminating malaria in the Americas. So with that, I'd like to now give the floor to our colleague Roberta Taides for the wrap-up session, closing remarks. Thank you very much, Roberta. Thank you, Sheila. Thank you, Dr. Andrew, Dr. Ivan, Christian, for your presentations. Thank you so much for the questions, for the answers. As Sheila indicated, I am Roberta Taide. I am GSK, or the GHS Programs Director, and I will be facilitating the last portion of this meeting. In this last session, we will have a presentation by Dr. Roberto Montoya, who, as you know, is our regional malaria regional advisor to PAHO. And next, we will hear a few remarks from some of the project's representatives who will be officially closing the session. So without further ado, let me give Roberto Montoya, Dr. Montoya, the floor. You have the floor. Feel free to share your presentation. We have earmarked 10 minutes for your presentation. Please go on.
Thank you very much for the organizers. Thank you, PAVE, and congratulations for this fantastic meeting. And thank you for all the participants and speakers. Fantastic information. I would like to share with you just a snapshot of the situation in the Americas as a backdrop. We have finished the consolidation of reported information from all countries, 2022 official data, and we finished up 2022 with the same number of cases we had in 2015. In the baseline of the global technical strategy for malaria at PAHO. So the challenge is tremendous. That is, we still have this outstanding objective to cut by 75% the percentage of malaria cases, but there is a favorable trend and a reduction in 2023. Interestingly, even though these figures look rather grim, interestingly, in these last 7 years, countries have implemented major program transformations for malaria control programs. Central America is leading the way in program changes and the control towards elimination. We still have a lot of tasks that show that much has to be done. The context for my presentation has to do with regional and country coordination. Of course, is the Plan of Action for Malaria Elimination 2021-2025. In 2 years, we will have to implement the next edition of the plan by 2030. So, partners, should establish action lines and priorities as a starting point for a coordinated regional initiative for the elimination of malaria. This is the development path for this action plan that will incorporate many initiatives that have been mentioned today. These are the key changes and the 5 top priorities in the control to elimination. I am convinced of the fact that first, we need micro planning. Malaria elimination, as we have seen so far, when we want to drop our levels below the plateau, we really need to consolidate malaria-free micro territories at micro level. That is the key to malaria elimination. Local malaria elimination, expanding access to diagnosis and treatment. The number 1 action plan is not same of the same, it's rather to overcome barriers, expand access, and definitely focus on what we have said today, identify efficient relapse Vivax relapses. This is essential, and we really need to implement changes that will lead us to elimination. I'm also convinced of the fact that effective strategies to prevent relapses and chemo prevention is something that we have to implement in the region. There are so many operational learning situations that we still need to clarify. But I believe that elimination of malaria in the region has to do with reactive interventions and chemo prevention, trying to improve coverage of vulnerable and priority communications with basic vector control initiatives. But of course, we need to close gaps in malaria policies, and we need to focus on policy gaps as the one we have just seen, health agents that cannot provide diagnosis and treatment in some countries, and how can we overcome these situations and close these policy gaps for the radical cure, chemo prevention, with regional coordination. I will talk about 3 topics. So, which are the changes towards elimination? First, consolidate malaria-free micro-territories, micro-planning to improve sentinel surveillance. This could really be the answer to bridging the policy gap, making progress towards radical elimination. Of course, tafenoquine is not the only answer. There are many aspects that we need to try to overcome with evidence-based initiatives. And of course, there are WHO recommended initiatives with targeted and reactive strategies for elimination. And I believe that there is an important agenda to go over policies and collect scientific evidence. I believe that at country process, we need to focus on these 4 top priorities. Identify policy gaps, we have mentioned this today. Address gaps in evidence, as is the case today, with so many examples. Design, validate, pilot new policies, and really implement them. And this is all connected with the global agenda in terms of policy generation and design. This is the global malaria plan. This is the factory of recommendations. And we need to make the connection. We, countries on the one hand, need to do our research and evidence analysis to implement policies that are recommended and endorsed, as well as participate in the initial debate on how to anticipate policy gaps and contribute with what has been the case with trust and other contributions, as is the case with Brazil and other partners, to the WHO policy initiative, with tafenoquine as the flagship example. So this agenda has to do with the identification of policy gaps. We have the technical group that helps us and supports us together with the standardization of protocols, tool development, financing, and the South-South Cooperation Technical Support Network, capacity building, exchange of information. That has been the case today, exchange of experience, because it is here where I see the major role of a coordinated initiative with stakeholders, as all the institutions that have supported us here in the region. The Malaria Technical Advisory Group at PAHO supports us, and we have focused on the radical cure. And in the Technical Advisory Group in 2023, we will focus on migrant malaria, chemoprevention interventions, and other initiatives that are really relevant to establish a dialogue between this technical advisory group and stakeholders in the region, as we have seen today, that will definitely make the difference. I believe that in closing, this is a joint initiative. We have seen fantastic examples of joint efforts, of course, and I run the risk of forgetting many institutions that have been supporting us, but it's just a reminder to say that we do firmly believe at PAHO that this is a joint effort with many stakeholders, and ultimately, I believe that countries, the main recipients of our initiatives, should really join in with all of these stakeholders to reach zero malaria. Thank you, PAVE and organizers, for this fantastic meeting. Thank you for having me.
Thank you, Dr. Roberto. As we say in Brazil, your presentation, you closed the discussion with the golden key, as we say in Brazil. But now I think that we can move on to the actual adjournment of the meeting. We can see now that we have 4 representatives here for the PAVE project. The first of them will be Janice Culpepper, who's a Senior Program Officer of the Strategic Team in Malaria, the Global Health Division of the Bill and Melinda Gates Foundation, after whom we'll hear Matthew Black, who is the Program Manager at UNITAID, after whom Gonçalo Domingos, the Scientific Director, and to conclude, we'll hear George Jiggle, who is Executive Vice President of MMV. So, Janice Culpepper, please, if you can hear us, please feel free to speak. You have the floor.
Thank you, Roberta. I don't have any slides and I will speak in English. First, I want to thank all the speakers. It's really a tremendous meeting today. I think it was just really exciting to see so much progress since the last PAVE meeting. And in addition to thanking the speakers, to thank the country programs and all the researchers who do all the work that underlies what we saw today. Super important, and I would also echo partnership is so critical in this area. I was particularly excited to see so much nice work on G6PD testing, training staff to do it. Really, I think that has been long overdue, and it is so nice to see that moving forward to support either tafenoquine or shorter course primaquine. So I think that's really going to be helpful in moving us to the elimination, particularly of Vivax. I also want to congratulate Brazil and say hi to Cassio for all of your efforts to move to elimination. I think the program is really exciting. And I think your comments around how maybe tafenoquine is not the silver bullet, but it is a tool that's really helping to accelerate the thinking around how can Latin America move to elimination, because it does help to remove one of the key hurdles. So I think giving radical cure along with the testing is really going to be important. And I think that's been echoed throughout the meeting. And so I think, thinking about that and what we just heard from PAHO, how do we really move forward with the planning and thinking about how do we incorporate these new tools and use them in such a way that really Latin America can eliminate malaria by 2030. And then a special thanks to all the supporting partners who will be speaking after me, UNITAID, PATH, MMV, Global Fund, for all of the funding and work you put into this to make sure that the work gets done on the ground, and that we actually can get to a malaria-free Latin America by 2030. So thank you, and I will turn it back to you, Roberta.
Obrigada, Janice.
Thank you very much, Janice. I'll turn the floor over to Matthew Black. Matthew?
Thank you. Thank you very much, Roberta. So, yeah, Matthew Black from Unitate, and I'm the program manager for the PAVE grant on the Unitate side. And I'm really glad to be here at the PAVE meeting for Latin America, I guess the fourth one. So thanks to PAVE for asking me to be a part of this closing session as well. Just to maybe give a background, because not everyone always knows who Unitate is. Unitate is an agency housed at the World Health Organization in Geneva. We save lives by making new health products available and affordable for people in low and middle income countries, finding and investing innovative products and solutions, then working with the countries and partners to take them to scale. And we've unlocked access to more than 100 health products across HIV, TB, and malaria, women-child health, pandemic prevention, and more than 170 million people have benefited from the products we've helped roll out. So also one thing I wanted to point out that's kind of relevant, I think, to some of the discussions today is that our latest strategy looks to raise our efforts in certain cross-cutting factors, such as mitigating and adapting to climate change, ensuring meaningful community engagement, and promoting regional manufacturing. And certainly I feel like the first two I heard elements of in discussions today, and I think all three of them are important things for us to consider in the malaria sphere. Our malaria portfolio is quite broad because we know that no single tool can end malaria. So we've invested in things from seasonal malaria chemo prevention, and then introducing updated vector control tools, such as the new dual active ingredient nets and spatial repellents. But then also anti-malarial drugs in areas of high or emerging resistance, and also looking at how we can use insecticides to stop malaria transmission amongst populations. But Plasmodium Vivax malaria is a complex and persistent problem, and something that Unitate assessed as being an essential gap in the overall malaria elimination efforts. So we're really proud that this has resulted in our engagement with the PAVE initiative, and that financing of the studies to test the feasibility of radical cure in Indonesia, Papua New Guinea, Vietnam, Ethiopia, and in this region, Peru, are very important to us. And we're very confident that the work that's being done by the PAVE team will lead to better drug modalities for pediatrics and will advance effective tools. So it's really good to hear the progress and the discussions coming today. And today's been very useful for me in terms of my learning, and I think really good to see the engagement that's going on across Latin America. The progress of the G6PD pilots, it was really good for me to maybe hear some of those for the first time. And the trust results maybe is something that we're all more familiar with, but like I think as Jonathan said, Brazil's been a pioneer in terms of Vivax malaria, and the next steps to scale up Vivax treatment across Brazil by 2026 are really exciting. And the emphasis given by Dr. Cassio and the other partners from the private sector about the need for the ministry, the public sector, the private sector, and academia all to work together to make this a reality was very impressive to hear. I also appreciated really hearing about how countries are zeroing in on vulnerable populations such as illegal miners, migrant communities, and indigenous peoples. And I think that's a message I'll take away back to my team about thinking about how that nuances with some of the work we're doing. Finally, right at the end, actually, Dr. Montoya from PAHO, when you highlighted the regional partnership at UNITAID, when you highlighted regional partnership, we at UNITAID view Latin America as really an example for other regions in terms of this. So I'll stop there, but just to say thank you very much, everyone, for what was really, really a very engaging and educative session. Thank you so much.
Obrigada, Matthew.
Thank you, Matthew. So now we'll hear Dr. Gonzalo Domingo.
Hello. First of all, I would like to thank all of the speakers for such great presentations, so informative. I really want to thank the Bill and Melinda Gates Foundation for financing that were the starting point of all of these catalytic activities to kick off all of these research work and collaborations. This was made possible through the development and planning of innovative product registration in countries in the region. And of course, today's presentations have really shown the essential role of this financing for partnering, collaboration, and speeding up research as input for evidence and incorporate all of these new technologies on the way to malaria elimination in the region, finishing up with Brazil's study that we're currently that we have shared today, that has shown and given us fantastic results that show that we can really include our initiatives in the elimination of malaria. Everything has been possible thanks once again to the vision of the foundation that invested in Vivax project together with UNITAID's support, continuation for the development of partnership for Vivax Elimination, PAVE. Thank you, all of you, for your participation, and as many have said today, I have learned so much today with you all. And let's keep up this good work till 2024. I'm really very happy.
Obrigada, Gonzalo.
Thank you very much, Gonzalo Domingo. And finally, we'll hear George Jago. I'm going to speak in Spanish rather than Portuguese. Thank you very much, Roberta.
Thank you so much. I'm the last one, and I guess everybody really wants to grab some coffee. My comments will be very brief. I will give you some previews on what we can expect. We're really looking forward for 2024 with WHO guidelines for the use of tafenoquine and G6PD testing, which can really be available in 2024. So in a couple of months, we will really update guidelines. But also, at the end of this year, we were really see that PAVE was born. The Partnership for Vivax Elimination was the joint effort in this 5-year journey with Bill and Melinda Gates Foundation and UNITAID, but the Gates Foundation will not renew their support in these new periods, unfortunately. So we really keep up our enthusiasm. We will make some adjustments along the way because we will not have the same capacity to be present with PAVE in so many countries. But the good thing is that PAVE supporters are giving us all of the technical support that we need in the region. So these regional meetings that have been so fruitful will continue in 2024 and 2025, of course. So in that sense, we need to thank UNITAID that will really keep on financing these meetings. Thank you so much, UNITAID. And thank you, UNITAID, once again for keeping up the implementation study in Peru, as we heard before. In 2024, we will see the results and we will be able to have results available as we do have now in Brazil. So first of all, thank you so much for all the countries that have supported us, the ministries of health, researchers. I mean, we're talking about the core of PAVE is what you're doing in this partnership for Vivax Elimination. If you didn't have the eagerness, curiosity, commitment, nothing would come to an end. PAVE exists thanks to you. So first, thank you to you all. Thank you. The second, thanks to PAHO supporting us with PAVE. PAVE was a strange creature in the beginning, but then with time and throughout the way, this joint path that we walked together, PAHO has been a great partner supporting the efforts that you are all doing through PAVE. And last, I would like to thank a group that is here behind scene in Brazil in these meetings, GHS, Roberta, her team, everybody in Brazil supporting us at GHS. Thank you so much, the team in Brazil headed by Roberta. So thank you so much to you all, our financing supporters, and I hope to see you soon, very soon.
Thank you, George. All good things come to an end. We've reached the end of our meeting. I want to thank everyone, one and all, for your participation, for your engagement, for all the discussion that we've had today. I hope that the meeting has been fruitful for you as well. And we also hope that we can see each other again very soon. So good afternoon, good evening, and thank you very much indeed. And we'll hope to see you soon.
Thank you so much, everyone. Bye-bye.
Chao, chao, gracias.
Hasta la próxima.
Chao, muchas gracias a todos.
Gracias a
Chao,
todos.
obrigado a todos.
Hasta luego.
See you soon.
See you. Bye-bye.
Ok. Obrigado, Paulo. Mandei a mensagem